All right. Hello, level 4 students. Welcome to the workshop for test 3 on shock, SIRS, MODS, ARDS, DIC. We'll briefly mention trauma and triage, but most of that you'll be responsible, as always, for going into your textbook and seeking out that information. Remember, that is your Bible for your studying. When it comes down to what do I need to know for the test, well, consult your reading. So with trauma, triage, also biochemical warfare, like sarin gas and tularemia and all those weaponized biologic weapons, make sure that you know those. I do believe that the 10th edition of the textbook has an online table that you can look at, but there are older editions that contain tables, and you can potentially get more information through there. That's up to you. But what's found in your textbook is what you're responsible for knowing for your test. So with that, we will start with shock. And I would love to once again introduce Miss Burgess. She was my level 4 instructor. I was blessed with her. And she is just a total champ, famous, featured on 60 Minutes, and previous aerobic instructor after a plane crash, so she's basically a superhero. So take advantage of her knowledge, and I'm going to let her go ahead and start. We are using some handouts from the NIP Student Commons. So if you need those handouts as we go through this, because it's pre-recorded, go ahead and print those out or have those available on your computer so that you can follow along. We may screen share them at some point, but it may be easier for you to have a printed copy to take notes on. And those can be found in the NIP Student Commons under course content and then level 4. And it'll be labeled according to each content area. So with that, I'll let Miss B take over.
Thank you. And I would just like to say thank you, Megan. I don't know if you all know, but Megan will be leaving us next week for larger pastures. Megan was definitely one of my favorite students, definitely the brightest, my protege, and I love her, and I'm just going to miss her immensely. I am no superhero. I am simply an example of God's goodness and mercy. Let me just tell you. But I do love this stuff. I have a lot of experience with trauma and critical care. And so we're going to try to impart some wisdom to you. And we're slowly getting some of the videos that they found that I have done in the past onto our actual NIP Commons. We're not going to have time to review ABGs here, but Megan already got my ABG lecture up there. It's like 45 minutes. So if you go to the NIP Commons where it says level 4, like Megan said, the handouts are there as well as that video. So we're going to start with shock. Now, when I say shock, some people think, okay, a blood pressure less than 90 and they're cold and clammy. Those are the clinical manifestations of shock. But shock is really a syndrome characterized by decreased tissue perfusion and impaired cellular metabolism. So there's an imbalance between oxygen supply and oxygen demand. So if you've listened to any of my lectures, you know this deal right here, and you better really understand it now. Because every cell in our body has to have oxygen to function. So through the process of aerobic metabolism, we're able to create 36 to 42 ATP molecules, adenosine triphosphate, which is the powerhouse of every cell. It's what makes the cardiac cell conduct electricity and the myocardial fibrils to contract and our neurons to send out signals. So it's really important. It is the power. When we are getting enough oxygen to the cells, so remember the process of perfusion, and I say it's the pump, the heart, pushing the precious prime, your hemoglobin train, and enough fluid in the river, precisely through the pipes, your arteries, your arterioles, capillaries, the capillary membranes, that's where diffusion takes place. Good things to the cells, and products back into the pipes, venules, veins, back into the right side of the heart, and then into the lungs, to get rid of CO2 and bring back in oxygen. So the pump pushing the precious prime precisely through the pipes to the point of purpose, which is every cell, so we can have aerobic metabolism. So we're going to break shock down into pump problems, prime problems, and pipe problems. And there's also an obstructive form of shock that we will deal with. But the problem is, this is the basic issue with any kind of shock. I call it piss poor perfusion. Not enough perfusion to the kidneys to make urine. Bad, bad thing. So when I have adequate perfusion, I can make 36 to 42 ATP molecules. That breaks down in H2CO3, which is carbonic acid, which further breaks down into bicarb and hydrogen, okay? Hydrogen is an acid, bicarb is a base. And in order to keep our pH 735 to 745, we have to have a 20-to-1 ratio, 20 parts bicarb to every 1 part acid. We also know that CO2 is an acid, correct? So we have to keep good, adequate perfusion to keep this 20-to-1 balance. This then further breaks down into CO2, which I can exhale, and water, which I can keep in my river, and or I can excrete it through the kidneys. This is how we were created to function. But if there is a problem with any one of those P's, the pump, we're going to talk about cardiogenic shock, the prime, hemorrhagic or hypovolemic shock, the pipes, anaphylactic, septic, and neurogenic, or obstructive, then we switch into what we call anaerobic. Not enough oxygen supply to the cells, so now I've switched into anaerobic, which gives me about 4 to 6 ATP molecules, not a whole lot, not going to sustain life for long, and a boatload of lactic acid. So what do we need to do? Well, we need to be able to identify when someone is going into a shock state, identify which shock state it is, and then we need to adequately respond for treatment, because we're going to start seeing these people go from compensatory to uncompensatory to refractory phases of shock. And if it gets to that point, then we just need to call the coroner, because it's all over. Okay, so what we're going to do is we're going to start with the different types of shock. So I'm going to screen share here. Excuse me. Okay.
And, one thing real quick, when Miss B was talking about in the river, that we keep fluid in the river, it sort of sounded like liver, but what she said was river, and that's the prime. So like our plasma, just in case somebody misheard that.
Thank you. Yes, the liver's important, but not for that. Very good.
Yeah, we don't want fluid in the liver.
That's never good. Okay, so we already identified shock as a disturbance of circulation and metabolism. Okay, we already went through that whole thing. We're going to skip down. We're going to come back to the stages of shock. And so what I want you to do on this handout is to scroll down to where you see our first classification of shock. I told you I break it down into pump and prime and pipes. So the first one is pump, obviously, and that's cardiogenic shock. And it can be systolic and or diastolic or both. And it's just like systolic heart failure, when the ejection fraction is less than 50%. Diastolic, when it's not feeling well, it's stiff and non-compliant, but it still hasn't lost that squeeze. So cardiogenic shock is diastolic ineffective filling. So that leads to not enough preload, which is going to decrease my stroke volume, which will ultimately decrease my cardiac output. Systolic ineffective forward movement. So it's resulting from a decreased ejection fraction. Now, some places say less than 50%. The book says less than 45%. Anywhere in there, that is a bad ejection fraction. Remember, the ejection fraction is just taking an ultrasound, looking at the heart, and looking at the volume in the ventricle prior to contraction, looking at the preload. Then it waits for the heart to contract, and it looks how much is left. So let's say that there was 100 mils preload, and then the heart contracted, and what was left was 40 mils. Well, that's a 60% ejection fraction. That's good. Conversely, if the heart is failing, and we see that there was 100 mils prior, and now there's 60 still left after it's ejected, well, that's a 40% ejection fraction, and that is a heart failing, that is cardiogenic pump. By the way, pump is the biggest P in perfusion. So pump failure, cardiogenic shock has a 50 to 85% mortality rate, not good. What can cause it? The person can have an MI, okay? Anything that damages the myocardial muscle. It could be a infection of the myocardium or pericardial sac, a pericarditis, a cardiomyopathy, could be due to drug toxicity, severe pulmonary hypertension leading to cor pulmonale where the right side of the heart fails, or systemic hypertension. A lot of times the heart poops out from people who have had hypertension for years, and their afterload is so high that poor heart has been going like blowing through a piccolo trying to stroke out that stroke volume, and it eventually just weakens and fails. All right, so what do we see? Now, what I want you to do, guys, is really pick up on the small, specific things that are unique to each type of shock. Okay, so we're going to see clinical manifestations of mental impairment. Well, that's no different than any other shock because the brain needs a constant supply of oxygen. But here is what will be different in cardiogenic shock that will not be in any other shock. The preloads are going to be high. So the CVP, which tells you the preload of the right ventricle, which should be no higher than 8 millimeters of mercury, is going to be high. And the pulmonary capillary wedge pressure, or since we don't wedge anymore, the pulmonary artery diastolic pressure, telling us that preload in the left ventricle is going to be high, over 12 millimeters of mercury. And we're going to see,
I'm sorry to interrupt, but when you hear an instructor or someone tell you this is the hallmark, what I want you to do in your notes is to make it as like gauche as possible in your handwriting, whatever, like all caps, hallmark. This is the only type of shock, other than I believe obstructive, where
right.
you're going to have increased pressures within the chambers. Because it's a problem with fluid overloading the heart to where it's so backed up. Remember that the principle, like Frank Starling's law, that the degree of stretch corresponds to the degree of strength of contraction. Well, that no longer works anymore because the ventricle's hypertrophied. So hypertrophy means an increase in cell size without an increase in cell function. Meaning that even though that muscle's gotten really, really big, like really buff, been working out in the gym, it's not going to be, it's pathologically formed. So it's not actually going to produce adequate cardiac output. And that means that all that blood's just going to keep backing up the pathway that it came from, essentially.
I told you she was brilliant. It's much like thinking about a rubber band. The further you stretch it, the further it goes. But at a point, you overstretch that rubber band and now it's weak and ineffective. And that's what cardiogenic shock is. Yes. And I'm glad you brought up obstructive shock because that, if we have something like, we'll talk about that, but sometimes that can actually lead back to cardiogenic shock, causing the pump to failure. And again, those preload levels are going to be up. Okay, perfect. So let's talk about this. What are you going to see? We already talked about mental impairment, but again, the hallmark signs, CVP and pulmonary capillary wedge pressure are up. Tachycardia, we see that in all shocks. Low blood pressure and cardiac output. But here's another thing. There's no fluid loss. We haven't lost fluid. Elevated right and left preload. That's why we say increased CVP, increased wedge. Dusky skin color, delayed cap refill, and your pulmonary capillary wedge pressure is often up around 18-20, definitely over the 15. Decreased cardiac output. We already told you that the normal cardiac output is 4 to 8 liters a minute, but more specifically, it's looking at cardiac index, and I believe, yes, still less than, you want to have a cardiac index of greater than 2.5 liters a minute. Otherwise, that's called cardiogenic shock. So remember, if I'm a normal sized person and I have a cardiac output of 4, but I have this huge guy who's 6'7" and he's 300 pounds and he has a cardiac output of 4 and we decide to run, I might be okay for a mile. He might pass out after a half a mile because he has much more body surface. So the cardiac index is simply the cardiac output divided by the body surface area, and that's what it gives you. So definitely know when you're looking at questions, if it's a cardiac index of less than 2.5 and your CVP and or your wedge are up, you're thinking pump, cardiogenic shock. This is the only shock.
Oh, go ahead.
No, go.
The only thing I wanted to point out was it says number 4 with no loss of fluid in bold. Why don't we have loss of fluid? What is ischemic in our body when our heart is not working? What are the eyes to the cardiovascular system? The kidneys. So the kidneys are being hypoperfused. They think that it's a problem with not only vasomotor tone, but they think it's a problem with actual volume. No, we're overloaded when it comes to volume. RAS is overactive in situations like this to the point that the kidneys are not remedying themselves the way that they should be treating the cause. It's not to say that the kidneys aren't highly, like what I like to call intelligent. It's that the only mechanism that they know how to perform in order to get more perfusion to themselves is to increase the pressure gradient so that it gets more blood flow, but also increase the blood volume with aldosterone. So if we're retaining all that sodium in water and excreting potassium, that means that we're not losing very much fluid at all. We're not putting any urine output, because our kidneys basically think that we're going into hypovolemic shock,
Right.
because they're ischemic.
That's a great point. Let's just go over that, because all the medications that we give for cardiogenic shock, or a lot of them, and the medications that we give for heart failure and decreasing afterload all have to do with RAS. Remember, the kidneys, like Megan said, don't know why they're not getting perfused. They're not getting perfused, so they do this little dance called razzmatazz. They secrete renin. Renin makes angiotensinogen from the liver, turned into angiotensin 1, and then from angiotensin 1, it turns to angiotensin 2 in the lungs. Well, what does that do? It makes your pipes, okay, angiotensin 1 can't do anything. Angiotensin 2 puts a major clamp down. It's a very potent vasoconstrictor. Why do I want to vasoconstrict? Because I have limited perfusion. I don't need perfusion to my duodenum and my sex organs right now, or my skin. I need it to my brain, heart, and lungs. Okay, that's why we see decreased bowel sounds. We have pale, clammy skin, because we're shunning blood away from non-essential organs and to the essential organs. And so you guys know, when you give ACE inhibitors, you're giving it right here. Enalapril, captopril, cardiazem. Remember the little saying, lumberjack Zem took the pine to the mill. Meds that end in those are ACE inhibitors. Now,
those are the calcium channel blockers.
I'm so sorry. Those are
That's okay. It happens to me all the time.
Oh my gosh, the ACE inhibitors end in
Pril.
So
I know where you got it from, though, because verapamil is the one that's a calcium channel blocker, and I always think it's an ACE inhibitor because it sounds like Pril.
Thank you.
That's where it falls apart.
I got a brain tooth. Sorry. Okay.
Me
I'm
too.
The second thing that angiotensin 2 does is it makes your adrenal glands, those little cute things that hang on to the renals, the adrenals.
I like to call them the kidney hats.
Kidney hats. I like it. They add to the renals. They're so cute. And they make you reabsorb salt, which is sodium. So where sodium is reabsorbed, that means potassium is excreted. And we know that where sodium goes, that's going to make your osmolality go high. So ADH gets involved, antidiuretic hormone, and we increase our water, which if this was hypovolemic shock, that would be good, but this is cardiogenic shock. So it is counterproductive. And then we have the sympathetic nervous system, and we have epi, and we have norepi, which are positive chronotropic. They're going to increase the heart rate, and they're positive inotropic, making it contract more forcefully. But when you do that, you're requiring more myocardial oxygen consumption. So it becomes very counterproductive. So what do we need to do? We need to treat the cause. If this is an ischemic issue, one of the coronary arteries is blocked, they're going to do angioplasty or a thrombolytic therapy. They're going to go get a percutaneous transluminal intervention. Because the heart is weak and there's no fluid loss, watch your IVs and other fluids because they're fluid volume overloaded. So we're probably going to have to give them diuretics. All right. If that doesn't work, they might have to do aquapheresis where they're just taking fluid off. They might have to actually go and do dialysis if the kidneys are not working. Positive inotropic drugs, Dobutrex and dopamine, they help increase the force of contraction, okay, but they don't increase the heart rate as much as epi or norepi. We want to remember, increase the contractile, but we want to decrease the force it has to work against, that pressure that it has to overcome to eject the stroke volume. So we want to decrease afterload. So that would be nitrite, nitrates, because they cause vasodilation. This would decrease the workload of the heart and decrease myocardial oxygen demand. Another great drug is Inocorp, known as Amrenon, and it's both a positive inotrope and a vasodilator. So it increases force of contraction, but decreases afterload and preload. We already talked last one, so I'm not going to get into this, about the use of an intra-aortic balloon pump or ventricular assist device to help increase coronary and cerebral perfusion and decrease afterload. They can actually put the patient on ECMO, but that's like the end of all ends. And that would be extracorporeal membrane oxygenation, where they actually take the blood out of the body, run it through a machine that oxygenates it and puts it back in. But there's lots of complications with that, DIC being a big one, which we're going to talk about later. So that is the big things with cardiogenic shock. Also, when you look in your shock chapter, there is a great, it's table 66.1, classification of shock states. It really breaks it down, and it is going to pull out for you the most important characteristics, unique characteristics of each one. So make sure you look at that along with our handouts. All right, let's go to one of the most common types of shock. And so we just did the pump shock. Now this is one of the prime shocks. It is hypovolemic shock. And hypovolemic shock occurs from inadequate fluid volume in the intravascular space. Remember, fluid has to be in the river before it can go through the interstitial space, like the little creeks, into your ponds or your cells. So there's inadequate first volume in the intravascular space to support adequate perfusion. It can be broken down into absolute hypovolemic shock and relative. All it means is absolutely, I can see the blood, okay? They're losing it through hemorrhage, through vomiting, diarrhea, a fistula. Maybe they're hyperglycemic. I can see that they're excessively urinating. Diabetes insipidus, which you know I call diabetes insidious piss, because there's not enough ADH, so they're just peeing all that volume, or any kind of diuresis, okay? That is an absolute loss. I can absolutely see it, and it's coming out of the body. Whereas relative is intravascular fluid volume has moved out of the river, out of the vascular space, hasn't come out of the body. Unfortunately, it's sitting in the interstitial space, causing edema, or an intracavity space, like ascites, a third space. Could be from burns, bowel obstruction. We all know what people with low protein and low albumin, anything less than 3, because albumin is the major protein. It's in the river that has the big oncotic pool that helps keep the fluid in the river. If there's not enough albumin, then the fluid is going to leak out of the river, out of the pipes, and into the interstitial space. Think about this. If the fluid is in the interstitial space between my pipe and my cell, that is going to prevent adequate perfusion between the capillary and the cells. So it's a bad thing. So what do we see? The resulting decrease of intravascular fluid, not enough fluid in the pipes, my river dries up, okay? It's just like here in Florida, the rivers in late August, when it hasn't rained for a while, they get really, really low, decreased velocity, and you can now look down there and see a bunch of rocks. You can see the solid particles. So my osmolality is going to go up. I'm going to have decreased return from the venous side into my heart, which means decreased venous return, decreased preload, which leads to decreased stroke volume, the amount ejected out with each heartbeat, and ultimately decreased cardiac output. What am I going to see? Well, what do you see when you have fluid volume deficit? Poor skin turgor, right? Especially if it is an absolute type of fluid loss. I am high and dry. My sodium is going to be high because I'm intravascularly dry. My osmolality is going to be high because I'm intravascularly dry. So greater than 295 or whatever the latest level is in your book. Always go with the levels from your book. If the person has no momentation, they're going to be thirsty because their osmoreceptors are going to talk to the brain and say, hey, you're high and dry. You should drink. Oliguria, because if I don't have enough fluid in the river, I don't have enough fluid to my kidneys. So watch the kidneys, like Megan said. I say they are the eyes into the soul of the cardiovascular system. If they're not putting out at least 30 mils an hour or 0.5 mils per kilogram per hour and watch it for like 2 hours, that's piss poor perfusion. We have some kind of shock states or something going, or maybe the kidneys themselves are failing. Anxious, restlessness. Here's the difference. They're going to have low systemic and pulmonary preloads. CVP down, pulmonary capillary wedge pressure down. They're going to be tachycardic. They're going to be
That's also what we were talking about with cardiogenic shock. See those CVP and PCWP? Those are the only time those are elevated in a shock state is in cardiogenic or obstructive, which you don't spend too much time on that. But cardiogenic, the hallmark is that CVP and PCWP is so high because the heart is literally engorged with blood. It doesn't have the muscular capability to push that blood forward. And so it just keeps backing up and eventually just stays in the heart. So like you see here, hypovolemic shock, we have low CVP, low PCWP, and the other types of shock like anaphylactic, septic, neurogenic, our CVPs are going to be really low. But the hallmark for cardiogenic is that elevated CVP, elevated PCWP.
Very good. And also in cardiogenic, the systemic vascular resistance, it has a lot to do with your blood pressure, and it calculates in your cardiac output. And for the right side of the heart, it calculates your pulmonary vascular resistance, calculates your CVP, and your systemic vascular resistance uses your cardiac output, your blood pressure, and your pulmonary capillary wedge pressure. So the only time the SCR is going to be up and your pulmonary CVP, and your pulmonary artery wedge is only in pump shock. Okay,
the other thing I did want to mention real quick, hypovolemic shock, the values are going to change based on the cause. So if I have diabetes insipidus and like Miss B said, I'm insidiously pissing, that means with ADH, we know ADH influences only water. So I'm losing only water. So what happens in my blood serum is I look like I'm hypernatremic, where it's dilutional, not a dilutional hypernatremia, that's something else. You're hypernatremic from the loss of water, not from intake of sodium. Right. So if you can understand where that's coming from, you can understand how to treat it. The other thing I do want to mention too, because a previous semester or two ago, there was some confusion about hypovolemic versus hemorrhagic. I think of hemorrhagic shock as a sort of under this umbrella term of hypovolemic, and hemorrhagic is when you're losing blood. So if you're losing blood, of course your hemoglobin and hematocrit are going to drop. But if I'm losing plasma volume, my red blood cells get squished together because they don't have that water spreading them apart. So then my hemoglobin and hematocrit might go up because I'm dehydrated. So make sure you understand the difference between those two things. You need to know, and the question will probably give you enough information for you to deduce whether it's water loss, whether it's water and electrolyte loss, whether it's blood loss. So you need to understand what the cause is in order to understand what the treatment, but not only that, what the lab values and diagnostic tests will look like.
Fabulous. So we're going to talk a little bit more about that, but in hypovolemic, if it's true water, just fluid loss, your H&H will be up, just like your sodium will be high because you're intravascularly dry. In hemorrhagic, you're losing trains off your hemoglobin train, so your H&H will be down. So let's keep going here. Thank you, Meg. Again, low systemic and pulmonary preloads, tachycardia, tachypnea. I'm trying to blow off CO2 because now I'm in anaerobic metabolism. So increased depth of respirations and increased rate. My cardiac output will actually be up, okay, because of the sympathetic nervous system, because of razzmatazz for a while. My hemoglobin and hematocrit will be high if I'm dry because I lost fluid, and it will be low if I've lost blood. Just think about it. If I'm losing hemoglobin trains off of my cars off my hemoglobin train, my H&H will be down. So what am I going to do? Fluid replace. I've got to get a large bore IV, usually 2. It's acceptable to give isotonic crystalloids. We know that that would be 0.9% saline because it's compatible with blood. And with greater than 30% intravascular fluid volume, the compensatory mechanisms begin to fail, and then we start adding blood to the situation. Now, if this is a hemorrhagic, the person has a femoral cut from trauma, okay, we can see the blood, then we have to replace the blood, okay? Packed red blood cells. And so we know from the first workshop we did together that you have to type and cross-match them. Because if I give them an antigen they don't already have now, they're going to go into anaphylactic shock. So remember, don't give anybody something they don't already have. So the only blood without any antigens is O negative. It's the universal donor. So if I don't have time to type and cross-match them, I got to get some blood into this person. They're going to get O neg, okay? And then remember, for every couple units of packed red blood cells or whole blood cells, we also have to give fresh frozen plasma. That's where my clotting factors are, right? And so you watch your PT and your PTT, and we'll talk about DIC later. And you also have to give thrombocytes, platelets. Don't forget about those because they're not in your packed red blood cells. Okay, treatment, we just talked about that. Lactated ringers, we should be used with caution. Here's why. Lactic acid builds up, lactated ringers. The liver has to be working functionally to break down lactate. And that's why when we look at somebody in septic shock, we look at their lactic acids to see how well or how bad they're doing. And so if I have decreased perfusion, I don't want to bring more lactate into my body to make it get, because what the liver does is it converts it from lactate into bicarb, right? That's the sponge that soaks up the acid. If I don't have good perfusion, I don't want to give lactate. So you're never wrong to give normal saline. Internal versus external, when we talk about hemorrhagic shock, we have to identify the source, right? So go back to your trauma. Think about, you can be bleeding inside. Like if you think about my situation, I was in the plane crash. If you've never seen that video, Google my name, Diana Burgess, D-I-A-N-A Burgess, plane crash, and several come up. I was in a plane crash where my legs dislocated, my knees totally posteriorly dislocated, ruptured my popliteal arteries. I was actually internally hemorrhaging. And some smart nurse picked up on the fact that my lower legs were getting bigger, more and more swollen, right? I had compartment syndrome and had to do fasciotomy. Where else can blood hide? In the retroperitoneal cavity. Look at Cullen's sign, right? You around the umbilicus, okay? So maybe peritoneal bleeding or retroperitoneal, and that would be gray turners. You turn the person and there's a ecchymosis back around where their kidneys are. So Cullen's sign around the umbilicus, gray turners back there. Any swelling, decrease in pulses, you got to start thinking of, do I have compartment syndrome? Any compartment in the body, including your brain, that in compartmental pressure should never go greater than 15 millimeters of mercury. So look at fasciotomies and all that kind of stuff. If we have time, I might touch on a few things about trauma, but we got a lot to get through.
Yeah,
So
and there's also one thing I wanted to mention too from your previous test that you took for, your cardiac cath patients who come back. It may not, they're going into an artery, so it may not be apparent if they're bleeding. It's not just going to be like, oh, there's an arterial bleed spurting across the room. It could also be bleeding within the leg or the muscle, which causes compartment syndrome. So then what happens is you have to measure essentially each thigh to make sure that there's no bleeding occurring, that they're symmetrical. Basically, we typically want, and this is like a standard of beauty as well, is like perfect symmetry, right? So if we have one side of the body that's bigger than the other, we've got to think, oh, there's something going on. One side of the leg that's a different color than the other leg, we think about something might be going on with that leg. So what I want to emphasize to you guys is, like, when we say, oh, it's benign or it's not something to quite worry about, that doesn't mean don't do something. It means continue your vigilant assessment as a nurse.
Brilliant. And that assessment is level of consciousness, hemodynamic stability, blood pressure, heart rate, pulses, cap refill. Then looking at their lab, what's their H&H? What are their electrolytes doing? What's their lactate level doing? That will tell you, have I switched into anaerobic metabolism? Look at my arterial blood gases. Excuse me. And that is going to help us keep this person alive. Excuse me. I don't have COVID. I just get this way when I talk so much.
Allergies have been really bad this season.
Oh my goodness. Okay, so we talked about this. Establish a two-bore IVs. Give them normal saline. At least 30 mils per kilogram per hour. Type and cross match the patient. We can use O negative. Packed red blood cells will help increase the oxygen carrying capacity of the blood. But then we have to, after every couple units of that, we have to think about FFP, which has all of our clotting factors, except for cryoprecipitate has factor 8 and von Wilhelm's. That's specific. Platelets, so watch your thrombocytes. Megan, the normals for thrombocytes changed. It used to be 150 to 400,000. Has that changed? You never really want to get it below 150.
Very slightly in the 11th edition.
Okay.
I want to say that was the one that did not change, but let me check that.
That's okay. So just make sure you look. I believe 150 is the lowest.
And you guys, if you're not, oh, go ahead. Sorry.
No, go.
If you're not sure of the lab value, go to your appendix in the back of your med surg book and look it up, because that's the values that they're going to be based on. And just from then on, have an idea of what the general values are. But like what you really need to do is like know your facilities values, which they make it easy for you to know.
Fabulous. Okay, and then albumin, if the albumin gets low, especially if it was a hemorrhagic shock and we're losing a lot of albumin. After we stop the bleeding and after we get the fluid volume up, then we'll add albumin to try to make sure that the fluid stays indeed in the intravascular space. Okay.
The one thing I wanted to add about hemorrhagic too was that there's a 3-to-1 ratio. So for every 1 ml of blood lost, if you have isotonic fluids and you're not able to give that blood product right away, for every 1 ml of blood lost, we can give 3 mL of isotonic fluid.
Absolutely wonderful. And what can happen, guys, is as we're replacing this massive fluid volume, is the fluid can leak out of the pipes and go into the interstitial spaces and into the cavities. After my surgery, I had a 13-hour surgery to save my life. When they saw me in the ICU, my family said I looked like Jabba the Hutt. I had anasarca. I had fluid everywhere except where it should be, right? So they had to wait for my body to like reabsorb it naturally. They gave me some albumins to pull it back in, and then they had to give me some Lasix to get it through my kidneys. But it's quite the process, and you really have to be watching your patient very closely. Somebody who's in shock needs to be in a critical care situation. They're not going to be left out on the floor. So here's the deal.
Go ahead.
If you're a floor nurse, it's really essential for you to pick up on the signs that this person is going into shock and call a rapid and get them off your floor. Because if we wait till they're already in shock, and they might be down to the decompensatory phase of shock, and that's not good. Meg.
And luckily, a lot of hospitals have SIRS and sepsis alerts so that you can notify the physician. You are mandated to notify the physician if a SIRS alert comes up.
Which is great.
There was one thing I wanted to add. Hold on, I'm going to pause the recording real quick. All right, so I have remembered what I was going to say. So in terms of administering albumin, especially when you get to the trauma section and maybe there's some sort of burn involved, what really you need to consider with albumin is the integrity of the capillary membrane. Because if we give that albumin too soon and the capillary membrane is still punctured full of holes from the inflammatory response, and guys, you have to know the inflammatory response. When we learn in level 2, what the inflammatory response is, and that's often associated with wound care from level 1, what really clicked in my mind as a nursing student was that this doesn't just happen with wounds. This happens with not just on the surface, it happens literally in every tissue in our body. There's something, exactly, anything that causes some sort of damage or insult to any tissue in the body. So that's going to make more sense as we go through the different types of repercussions of shock. But what I'm saying is that albumin has to be timed in a certain way so that we know the capillary membrane permeability is enough to keep that albumin in the vessel. If it's not, it's going to pull the fluid that you're trying to replace, especially in the case of burns, back into the interstitial space.
Make it worse.
So yeah, it's going to make it so much worse. So just keep that in mind when you're thinking of albumin.
Yeah, perfect. So we would never give it when somebody already has classical signs of SIRS, systemic inflammatory response, which we're going to get into. Okay, so that was your, we did pump, cardiogenic. We did prime, which is absolute and
relative,
thank you. And we've kind of differentiated hypovolemic from hemorrhagic. Hemorrhagic is a form of hypovolemic, but you can be losing just fluid, or you can be losing just blood, or you're losing both. So
it's the story we've heard from the beginning of time, from level 1, where we're learning about fluid and electrolytes, and you're like, fluid volume overload, fluid volume excess, sodium overload, sodium excess. It all depends on the cause to where, am I losing sodium with water? Am I gaining too much sodium and not getting enough water with it?
Yeah, exactly. And so we're going to treat the cause. That's the bottom line. Okay, stop the bleeding, stop the fluid loss, and replace it as needed. Now we're going to be talking about pipe shock. They call it maldistribution, inappropriate vessel size. And we can break that down into neurogenic, septic, or anaphylactic. So let's talk about neurogenic. Your first test, we talked about closed head injuries, and we also talked about spinal cord injuries. So this is what's happening. It's an insult to your central nervous system. Loss of all voluntary and reflex neurological activity below the level of injury, that would be spinal shock, okay? Spinal shock, and pulling of blood within the peripheral vessels with no loss of fluid related to massive vasodilation without compensation due to loss of central nervous system constriction below the injury. So usually any spinal cord injury below T5, you're going to have, it's just like breaking a cord, an electrical cord. I think I showed that to you. I think I used my mixer.
Yeah.
When I was up in the mountain, that when you have that damage, you can't get the electrical surge down there. So no longer can your central sympathetic nervous system tell your vessels to vasoconstrict to keep blood up here, and all your blood is going to pool. Okay. Spinal anesthesia. If they did a spinal anesthesia for when a woman has a C-section or any kind of surgery, right? That can lead to it. Drugs that inhibit sympathetic nervous system, that inhibit peripheral vasoconstriction can all cause neurogenic shock, okay? Now, here are the clinical manifestations. Like Megan said, highlight them. Flaccid paralysis. This is the only shock where you should see paralysis because it's dealing with the central nervous system. And absence of reflexes below the injury. Hypotension, that's no different than hypovolemic shock or cardiogenic shock, really. CVP and their systemic vascular resistance are going to be low. Here's the hallmark. Because I have cut the effects of the sympathetic nervous system, I have unopposed parasympathetic nervous system, I'm going to have bradycardia. What? Doesn't it make sense if I'm going into shock, I'm razzmatazing to beat the band, I should have tachycardia. I can't, because I don't have any sympathetic nervous system control. My parasympathetic nervous system is going to bring my heart down. But I have a paralytic ileus, loss of normal temperature regulation, which we talked about with spinal cord injury. That's called poikiliothermia, where the lower extremity, anything below the level of injury, can no longer, when it's cold, vasoconstrict, or when it's hot, vasodilate. So it just takes on the temperature of the environment. Okay? You might, the treatment. Obviously treat the underlying cause. We have to stabilize the spinal cord. We have to prevent further injury above and below. Megan mentioned about what happens with the inflammatory process. Spinal shock may last days to months. Okay, that's what happens. And we know that it has resolved when reflexes return, but neurogenic shock can't last long or the person's going to die. Okay, but how do we treat this? I have to use vasoconstrictors to actually cause vasoconstriction to get the blood back up, increase venous return, increase preload, increase CVP. It will terminate when I have the return of reflexes, or they become hyperreflexic or very spastic, okay? And if we don't turn this around, that person's gonna die because they're not gonna have enough preload to make stroke volume, to make cardiac output. So this is a very common, very treatable form of shock. So if you have somebody who has had any kind of spinal anesthesia, spinal surgery, and or they've had a spinal cord injury, I think neurogenic shock. Okay?
Yep. And then also, we want to think about the prioritization of those treatments. So let's say that you're a first responder and you're on the scene and you see, someone's laying on the ground. They've obviously sustained a spinal cord injury, but you're not sure where. Well, before we do anything, we need to make sure that we don't make it worse. Do no harm, right? So we need to stabilize that cervical vertebrae with a C-collar. Like Miss B said, vasopressors like phenylephrine to counteract the vasodilation. Because remember, I think of neurogenic shock as essentially the total opposite of the sympathetic nervous system. Your pipes are open wide, your heart rate drops. That's what's causing the piss poor perfusion. Atropine is also going to be used to counteract the bradycardia, because we know that those beta receptors are part of the sympathetic nervous system, that they're initiated by epinephrine, and that increases our heart rate, right? Well, if our sympathetic nervous system sucks, then that's the medical term for it, by the way, in case you want to look like a doctor when you walk on the floor. So make sure that you are measuring their heart rate. You need to look at your patient. Are they hemodynamically stable? We can't emphasize that enough. Mm-hmm. The other thing I really want to emphasize for this one is that we don't have a problem with the amount of fluid if this is in isolation, because a lot of the time this happens with actual trauma. Like, let's say someone dove into an area of water where they thought it was deeper than it actually was, and it causes a cervical injury. Well, there may also be bleeding happening at the same time. So they could also be in neurogenic shock and hypovolemic or hemorrhagic shock. So it may or may not have something to do with how much fluid volume there is, which is why with neurogenic shock, this is another hallmark, cautious fluid administration. It's not usually a problem with the fluid, it's a problem with the pipes. It's a problem with partially, you know, the innervation of the pump. It's not that the pump is falling apart, it's that the nervous system is. And then from there, like Miss B said, monitor for hypothermia. But think about that in terms of which one's going to kill my patient first if I don't do this? Well, if I go and start messing with them without stabilizing their C-spine, their brainstem gets severed and I'm done. Like they're done. You know what I mean?
And
I'm
always
getting real intense right now.
always think airway, breathing, circulation. Guys, when you're looking at questions, it's always prioritizing. There might be 4 of the things you are going to do, but which one do you need to do first to keep them alive longer and not kill them, like Megan was saying. Also, don't forget that you can do things to patients that can actually put them into. We could actually give too many opioids or benzodiazepines. So then you would have to have romazicon on hand. And remember, hallmark, bradycardia. So get that atropine, get that vasoconstrictor, norepinephrine, dopamine, whatever it takes, and get those pumps clamped before we ever think about giving them more fluid. Okay, it's very cautious. Okay, and then treat the cause. All right, let's go to, I want to do septic last because it flows into SIRS, ARDS, and MODS. So let's go down here to anaphylactic. Okay, so anaphylactic is an acute life-threatening hypersensitivity, an allergic reaction to a sensitizing substance. So it's an antigen, right? It can be drugs, chemical, vaccine, food, insect, venom. The reaction quickly causes massive vasodilation. So it's going to cause vasodilation like neurogenic, but for a different reason. It's an antigen antibody reaction. And so what's going to happen in massive vasodilation, then we have release of vasoactive mediators or cytokines. And I try to explain cytokines is we all have those kin, those people in our family that are so easily excitable about anything. And they'll be like, oh God, Meg, did you hear about Aunt so-and-so and what she's doing? She's drinking too much. We need to do an intervention. Oh, let's get all excited. Let's all get over there and do something.
I'm the cell and I get all riled up, ready to throw it down. You know what I mean?
Ready.
I'm going. Ready.
And so
closing that airway. We're about to close that airway.
Too much, too soon, and it causes an issue. All right. So we have massive capillary permeability, and fluid is going to leak from the pipes out into that interstitial space. It can lead mainly to blockage of the airway, okay? So let's go back through here. We know that in the inflammatory response, the pro-vasoactive mediators like histamine, heparin, and your cytokines cause massive vasodilation. And again, if I vasodilate through gravity, all my blood is going to go south. I'm going to have pulling, which will decrease venous return, increase capillary permeability. I'm going to leak my fluid out into my interstitium. And then I'm going to have edema, and I'm going to have a dried up river. My river, my circulatory river is going to be in decreased circulating intravascular volume.
And so, think about what we talked about with cardiovascular, that anything that causes vasodilation in the periphery, that blood spends, I think of it as spending more time outside of the heart. It takes longer to get back to the heart. So what happens to preload? It decreases. And so we don't have enough volume. It's trapped somewhere else. It's not necessarily that we've lost volume. It's in the wrong space. It's not coming back to the heart the way that it should be to basically load up the heart for the next pump.
Exactly. Beautiful. Now remember, this antigens is crazy. An antigen is a protein or anything that's foreign to your body that your Mr. T, I pity the fool, comes up in here and I don't recognize him. I'm going to tag him and destroy him. Anything that doesn't belong in your body. So it can be drug, food, chemical. Now remember, it can be inhaled. It can be ingested. If it gets injected, that's going to be bad because it's immediately into your system. So your body, your Mr. T cells tag it, and there's an immune response like nobody's business. Now, what can happen is the first time Mr. T can go, hey, I see that antigen, I don't like it. Let's say the first time somebody eats shellfish. And then the second time is like, I remember that, and the person doesn't feel so good. But by the third time, Mr. T has told the whole Army, the Navy, and the Navy SEALs, and they're all coming. So it can be a progressive thing, or it could be the first time they were exposed to it. Honest to goodness, this happened to me I've had several anaphylactic things, and they were never in a good place. The first one, I was at 40,000 feet. I was a flight nurse. I was transporting a patient over to India. I had him on a ventilator. We had booked out seats on a commercial airline because it's cheaper than taking a Learjet across the pond. And there was the flight attendant came up and she goes, "You got to come back here." I go all the way back in coach back there, and in the middle of the 5 seats sits this man. What did Megan say? Airway. You get bronchoconstriction. This is called stridor, a high-pitched constriction from the bronchospasm. There's a decreased bronchial smooth muscle. It's constricted.
That's those leukotrienes. They're the ones that cause those smooth muscle of your airways to spaz out.
It is not good. So I knew that this was bad. I ran back to my kit where I had Benadryl and I had epinephrine. That's the treatment, right? Stop that histamine release and then get the sympathetic nervous system to react. And we saved this man. And later I'm talking to him. I said, "Well, do you have allergies?" He said, "Well, I have a pretty severe nut allergy." I said, "Would you go eat the peanuts?" He said, "No, but I was eating the dinner they gave me, and there was a little piece of cake, and on top was 1 almond sliver." He said, "So I just took the whole icing off the cake and ate just the cake." Problem was the almond oil had seeped down in there. Another time I was working in the lab at NIP, at SBC, at the HEC, and I heard one of the instructors came and got me and said, "Get out here." And there was a student who had been in the same classroom 3 times that week. Well, this was before we knew there was leaking in the roof and mold had accumulated in that room. And by the 3rd time she went in that week, right, Mr. T had tagged it, this antigen, this mold, and she had an anaphylactic reaction. She already had some asthma issues, and she's out there. Well, all I have is pretend, bronchodilators in our lab. So luckily she had albuterol, which is the sympathomimetic drug, right? It's a rescue inhaler. So you inhale sympathetic nervous system, epi, like right into your constricted bronchi, smooth muscle, and it opens up. And then we got 911 there for her. So anaphylactic will raise your blood pressure, the nurse, and increase your pucker factor by about 10 points. It is scary as all get out, right?
Yeah.
You have to react immediately. You want to try to get that away, whatever's causing the problem away. Here's what you're going to see: anxiety, dizziness, dyspnea, okay, bronchospasm, stridor. You're not going to see that in any other these other things. They'll have chest pain, edema, may have angioedema, swelling of the lips, right? Most often around the lips and the eyes. Urticaria, those are those hives, those raised, itchy, red welts on the surface of the skin. It's going to be very itchy. They might become incontinent. That's very common. They'll have a feeling of impending doom. Listen, when you're and you can't breathe, that's scary.
Yep.
You will have hypotension due to massive vasodilation. Remember, this is a pipe shock. So I will have decreased systemic vascular resistance and circulatory failure. Prevention by obtaining a thorough history is really the key here. Priority: airway, 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 right? Maintain airway, laryngeal edema, and bronchoconstriction. So we need a bronchodilator, albuterol, which is a sympathomimetic, or aerolized epinephrine, racemic epinephrine. Then the other drugs that we give are epinephrine. We can give it sub-Q, you can give it IV, and it will cause vasoconstriction to get the blood back and increase your preload, your stroke volume, and cardiac output. And also remember, it's epi, it has beta-1 effect on the heart, has beta-2, bronchodilation. It can be given IM, IV, or even nebulized. And then Benadryl. Usually, we can give that IM. You can give it sublingual if that's all you have. And remember, a lot of people who have allergies will carry an EpiPen. Volume
One of
expanders,
my
like,
closest friends does not, and I give her the hardest time about it, and so does her husband. And I'm like, I'm going to get one for myself for when I'm around you, because I don't want to be responsible for watching you go into this reaction.
oh, that's
The
scary.
one thing I did want to mention too, going back up to kind of the patho about it, because I do have a doceri workshop that I did for spring 2020 on inflammation and immunity. It's rather long. But one of the moments that it clicked for me in understanding what these antigens were and how they worked, you tell yourself a story. So for me, let's say we live in Europe where, 18-year-olds can go to bars. Here, you're underage, so like just visualize it if you haven't been there before. So what you do is, you go into a bar, let's say somebody makes a scene. and they're not supposed to be there. And so normally what a bartender will do is either take their driver's license or they'll make a copy of their driver's license. I think of that as the antigen. That's their identifying marker. And they put it on the back of the wall so that the bouncer knows and everybody knows who's not supposed to be there. And then like Miss B said, Mr. T comes in, he's the bouncer, and he sees the guy who walks in, or girl, girls can be crazy too. They come into the bar and the bouncer sees the driver's license on the wall and is like, no, you're not allowed in here. You got to get out. Maybe they give them a second chance. Maybe that's the second time they've been introduced to the antigen. So it's not as severe of an allergic reaction. But then they start doing it again, and now they're definitely not coming back. Well, the third time they show up, that bouncer's going to be like, get out of here. I don't want to see your face around here. That driver's license is staying on that wall for 30 years. It's like Pam from The Office got kicked out of Chili's. So just think about that when you're thinking about, your immune response, what those antigens are. You got to tell yourself stories. Make whatever story that makes sense to you. That's a study skill, to make it make sense to you so that you can understand what's going on.
And that's brilliant. And Mr. T, that bouncer, by the third time, he's just not going to do it by himself. He's going to get his fellow bouncers. He might call the cops. He might call the Boy Scouts. I mean, the more exposure to this irritating antigen, the more massive of the response. And it can be a one-time thing. I mean, some people don't know how sensitive they are. Here's another story. My respiratory therapist who flew with me for 20 years, she found out that, well, she didn't find out. She went and ate shellfish and wasn't feeling good. Went another time and still wasn't feeling good. She just thought maybe she got bad shellfish. She's with me and she has crabolytic crepes. She gets home and she's like, I'm really kind of struggling to breathe here. She finally goes to the ER, finds out that she has a severe allergic reaction to shellfish. So they gave her epi and they gave her the Benadryl and she went home. She went to another restaurant that wasn't a seafood restaurant, but they had oysters on the half shell. She just smelled it, started bronchoconstricting. So it can be very scary. All right, let's keep going here. We got to need to go back to our other pipe shock, which is, well, no, let me just mention obstructive shock, because then I want to kind of go from sepsis into SIRS and ARDS and MODS. Obstructive shock is caused by physical obstruction that impedes the filling or outflow of the heart, and that further decreases cardiac output. It can be caused by compressing or restricting of the right ventricle during diastole, the filling phase. It can be compression of the left ventricle so that it can decrease stroke volume and cardiac output, which ultimately results in decreased perfusion. So if somebody has trauma and they have abdominal compartment syndrome, okay, that can compress the inferior vena cava, decrease venous return. So what are they going to do? They're going to do an exploratory lap. They're going to fix whatever's bleeding in there. By the way, they can actually take a catheter into any cavity, the peritoneal cavity, the lower leg, the fascia, and they can read the pressure. And if it's over 15 millimeters of mercury, we have compartment syndrome. Here's some other examples. What would impede left outflow of the heart? Cardiac tamponade, too much fluid in that pericardial sac. A tension pneumothorax. Remember, if you have any kind of blunt chest trauma and you see paradoxical breathing, or you feel crepitus, you feel cracked ribs, that can pop your spongy lung. After my plane crash, I definitely had a pneumothorax, but they got a chest tube in before it became a tension pneumo. And at the end, we'll touch on chest tubes because you need to know about the functioning of those. Pulmonary emboli, okay? That's going to block blood flowing to your lung, and it's going to be wasted gas there. It can't get on the hemoglobin because you got a big old clot preventing blood going out your pulmonary artery into your pulmonary vasculature. Superior vena cava syndrome, a lot of time that's due to a tumor, could be from cancer, and a lot of times what they'll do is do palliative radiation. Abdominal compartment syndrome, anything, it's going to decrease the cardiac output and it's going to increase afterload, right? That's increasing the systemic vascular resistance. We'll see jugular venous distension. And here I would circle this. This is very, very specific to obstructive shock. Pulsus paradoxus. All right, what does that mean? Your systolic blood pressure will drop by at least 10 to 15 millimeters of mercury during inspiration. Remember, during inspiration, we pull fluid back into our central part of our body. So if this person is having pulsus paradoxus, where the systolic blood pressure is dropping, when I inspire, that could be a sign of obstructive shock. And treatment, always maintain airway patency, provide supplemental oxygen, intubate, put them on a ventilator. Fluid resuscitation may provide temporary relief of the decreased cardiac output, but we have to treat the obstruction. So if it's a tamponade, we have to do a pericardiocentesis. They might have to do a window where they, open an area of the pericardium to let it drain. Insert a chest tube to open back up. Remember, you have that negative pressure around your lungs, and if that becomes a positive pressure, then your lung is going to deflate. So they have to stick the chest tube in and put suction on it to allow it to reinflate. Otherwise, if I have a pneumo here, it's going to keep pressing on my mediastinum, causing pressure against my heart, decreasing cardiac output, increasing afterload, and then eventually I'll have a tension pneumo. By the way, if you wait to see a tracheal shift, that is a late sign of a impending very bad thing for someone who has a tension pneumothorax. Maintain airway, provides oxygen, intubate them, fluid resuscitation, treat the cause. That's the bottom line, okay? So either insert the chest tube for a pneumo or tension pneumo, and they might have to go in to have an embolectomy if they have a pulmonary emboli, okay? Okay, so now we're going to talk about probably the worst form of pipe shock, which is septic shock. And it's also known as warm or flushed shock. And I would make sure I knew that that was a characteristic of this type of shock. And every other kind of shock, they get cold, clammy skin. But here they're going to have an infection. So they're going to have a warm, flushed kind of appearance. Sepsis is a life-threatening syndrome in response to an infection. It's characterized by dysregulated patient response along with new organ dysfunction related to the infection. We're going to drill this down. But unfortunately, it can be caused by a gram-positive, gram-negative, a fungus, a virus, but in up to about 30% of patients with sepsis, the causative organism is never identified. Sepsis and septic shock have a very high incidence worldwide, a high mortality rate, 25%. So what happens is we get a microorganism that invades, okay, it could be gram-negative, that has a higher mortality. Some gram-positive, like in the case of toxic shock syndrome, could be from a virus or a fungus. In an invading organism causes a release of what we call an endotoxin. That's just what it is. To the endothelium of the pipes, which is synonymous to the inner lining of your pump, there is a toxin release that starts breaking that down and putting holes in it. And we have a release of pro-inflammatory cytokines, like we talked about. It's going to increase inflammation. And it's also there's also setting up increased clotting, which is going to be a factor of us going into DIC. Damage of the endothelium. So now like Megan was talking about, your capillaries are leaking. So fluid's going where it shouldn't. It's not staying in the river. It's leaking out into the interstitium. We have increased inflammation, and we also start our clotting mechanisms. And so little small microthrombi get out into our distal perfusion, out into our fingers and our toes. We have vasodilation with selective vasoconstriction. So now we have maldistribution of circulating blood volume. We have decreased tissue perfusion and decreased impaired cellular metabolism. These people go from aerobic to anaerobic. Remember, the key to inflammation is vasodilation, which allows fluid to leak into that interstitial space, also because of the endotoxins putting holes in our capillary. So the fluid leaks leaks into the interstitial spaces from our pipes. Also, during an inflammatory response, the body's temperature is going to go up and the metabolic rate increases. That's why we're going to feel warmth and we're going to see flushing. So
one thing I wanted to add too, not to interrupt, but I want to really reinforce to you guys that the inflammatory response isn't just, vascular. It's not just cellular. It's not just, chemical mediators. It has a lot to do with coagulation. And I think that's where a gap resides in understanding, not placing blame anywhere, just saying there's this big gap in understanding that the inflammatory response is closely related to the coagulation cascade.
That's
because what the body thinks is usually happening is the body's extremely afraid of losing volume. It's extremely afraid of pathogens entering. And by losing volume, I also mean hemorrhage. So what's happening with this inflammatory response is that we have overclotting. We have clotting throughout the entire body. So one part that's often left off of the inflammatory response is what's happening with the coagulation cascade. Because not only is the inflammatory response, initially we have that period of brief vasoconstriction, and that's primarily to stop blood from leaving the vessels. From there, we have time to get that coagulation cascade set in motion, meaning that like these things don't happen in isolation, they happen all at once. So that at a certain point, vasodilation can occur, which opens up the vessels to bring white blood cells to basically flush out all of the nasty stuff. Yeah, and so that those white blood cells can migrate into the tissues. Well, please keep in mind that when we're talking about systemic inflammatory response syndrome, which is going to be part of sepsis, we're also talking about the hematologic system. We're also talking about the coagulation cascade, which can be life-threatening. And you guys go back to your notes if you have to, and go back to that dossier that I did in spring 2020, which is under the NIP Commons, refresh just that inflammatory response part, because that is essential in understanding MODS, ARDS, DIC, sepsis. You have to understand it because that's what's happening.
Brilliant.
I'm done with my little soapbox.
I like it. That was a good commercial. I like it. Okay. So septic shock is a subset of sepsis. So let's talk about this. Sepsis is systemic response to a suspected or documented infection. Okay. It doesn't even have to be that we know. All right. They start presenting with some clinical manifestations that we know we see a systemic response. We have seen a systemic inflammatory response. Severe sepsis is sepsis complicated by organ dysfunction. So all of a sudden, this exaggerated inflammatory response and this exaggerated clotting thing prevents distal perfusion to central organs. And each time an organ fails, if we get two or more, we call that multi-organ dysfunction syndrome. And the mortality rate increases to 50%. Each time another organ fails, it goes up. We're going to talk specifically about that. Septic shock is sepsis with hypotension despite fluid resuscitation. Please understand that. So they have a suspected or a documented infection, and they have hypotension, regardless of the fact that we gave them adequate fluid resuscitation. How do I know I gave them adequate fluid resuscitation? I'm glad you asked. I need to give them crystalloids until I get that CBP, telling me preload back to the right side of the heart, up at 8. Once I do that, and I still can't get perfusion, I'm going to have to go into vasoconstrictors. This is maldistribution. Some of the body will be hypoperfused, warm, while others will be underperfused. You probably have cold hands, cold feet, but their central body might be warm to touch because they're probably going to be febrile. So this is the pink, warm, flush skin. That is the telltale characteristic sign of septic shock. Initially, because of razzmatazz, right, we're going to have a hyperdynamic state. So my cardiac output will be up, and because of this immense dilating of my pipes, I'm going to have a decrease in systemic vascular resistance. Increased intravascular fluid shift. Now remember, all these pro-inflammatory cytokines are causing leakings, and that the actual causative organism is causing endothelial damage. So my capillaries are leaking. Fluid is leaving my river, heading out into the interstitial space. So what's left is getting thick and clotty in the river, right? So that's I'm going to see increase in hematocrit. I'm going to see an increase in blood viscosity. We know that that's not good because that increases clotting. So now we have microemboli forming due to release of platelet activating factors, which is one of those pro-inflammatory cytokines, and I have decreased tissue perfusion. So normally whenever I start clotting, I have thrombolytic right behind it to break it down. But the thrombolytic system is depressed in this septic shock. So what am I going to see? Well, because I have an invading organism, I have increased temperature because of pyrogenics. Remember, that's going to lead to my hypothalamus saying, hey, there's an abnormal kind of pathogen in here. Let's cook them out, all right? Increased white count, right? And we also see a shift to the left. What do I mean? A shift to the left, when you look at your lab work, you see an increase in white blood cells overall, but you also see an increase in bands. Those are those little baby white cells that have just been, just been created in your bone marrow, and they're circulating around, sucking their thumb, and then the body's going, no, heck no, get out there and fight this infection. They're like, no, I'm just a baby, I can't do it. So you see all this increase in baby band white blood cells. We know we have an acute infection. Okay. We have
The way I remember that too is that in World War II, at the very, very end, when the Nazis were obviously losing, what they would do is they would put children less than 18, they would put older adults that were not meant to be on the front lines, because that, like, literally their entire army had been decimated. So this is essentially what's happening. We're at war in our body, and we're running out of competent soldiers. So now they're throwing in immature cells that look banded. That's why they're called bands. And so they're being put on the front lines when they really shouldn't be.
That's a great analogy. I like that.
Thanks.
Okay, so we get increased white count, increased temp, increased metabolic rate, the heart rate. This is where you get a bounding pulse. I'm talking about 4+ pulses. That's why when you check pulses, don't just check them for symmetry, check them for strength. They're in a hypermetabolic state. They're going to have pulmonary edema. Why? Because all the capillaries are leaking due to the damage from the endotoxins. So what do you think? If you have fluid leaking in your pulmonary capillary, now fluid is going to be between your alveoli, and it's also going to be between, by the way, I just broke this down, pump shock, prime, and there's your pipes. And
we might have to stop the share just so we can see the board. Let me
Say
just,
it again.
I'm going to stop the share so we can see the board up close.
Oh, I'm sorry.
No, you're good.
Can you see it now?
I'm going to share my screen, and then I'm just going to cancel my share.
Okay.
Stop
I could have
share.
just canceled my share.
There we go.
Okay. So remember, pump shock is, we have increased CVP, increased wedge, increased SVR. The prime is the hypovolemic and the hemorrhagic, decreased CVP, decreased SVR. And if it's hemorrhagic, it's decreased H&H. And then the pipe shock, neurogenic, anaphylactic, and septic. And septic is the one that we're talking about. But when you have the endothelium of your capillaries being damaged, okay, so let's say that this is a pulmonary capillary, and this is an alveoli, okay? Remember, the hemoglobin train's coming through here, and oxygen is supposed to get onto the hemoglobin train, and CO2 returning is supposed to get up here so I can exhale it. But what happens is these capillaries become permeable, and some of the fluid from the river starts leaking out into the interstitium and eventually leaks into my alveoli, causing pulmonary edema. If I have pulmonary edema, I have fluid in my alveoli, can I gas exchange anymore? No. It also, at the same time, is going to flush out type 2 pneumocytes that create this wonderful thing called surfactant. And we're going to be talking about ARDS. And surfactant is a phospholipid, much like Dawn dish detergent, that helps keep the alveoli open. If we rinse that out of there, these alveoli, when we expire, are going to collapse and not come back over. We're going to have atelectic stiff lungs. And we'll talk about that when we talk to ARDS. Okay, let's go back to that handout, please, Miss Meg.
Yeah, you got that on your screen?
Let's see. I think did you turn us off?
I just stopped sharing your screen so that we could see the whole thing. But if you click share screen, I can pause it. You got it?
Got it back. Okay.
Yay.
Thank you. All right. So now, respiratory failure will develop in 85% of the people, 85% of the population for what I just showed you right there. Okay. Decreased urine output, metabolic acidosis from the buildup of lactic acid because they now shift from aerobic to anaerobic metabolism. 85 are going to go into respiratory failure. Do you think that sepsis is a killer? Yes, it is. Now,
the other thing I wanted to add about, what happens with the heart, certain types of bacteria release endotoxins that are going to be myocardial suppressants. So even if you do have this bounding pulse, we realize that the heart can only sustain itself for so long, especially if those endotoxins are being released, suppressing those myocardial fibers.
Thank you for saying that, because I had forgot to say that, because initially that cardiac output is going to be increased. And if we don't treat the causing organism, that cardiac output is eventually going to fail.
And then we've got cardiogenic shock on top of that. So it's that's why we enforce from level 1, holistic. Like, things don't happen in isolation the way that they do when you're studying them from your textbook. We're looking at everything.
Okay, let's finish this handout, then we're going to go to the other handout. So diagnostic criteria, the person is going to be, can have hyper or hypothermia. So anything above 100.9, less than 97, heartbeat greater than 90, tachypnea, either leukocytosis, a white count greater than 12,000 or less than 4,000, arterial hypotension, systolic less than 90, and their mean arterial. Remember, you get a mean arterial by taking one systolic plus 2 times the diastolic divided by 3. And if that is less than 70, that's a sign. Or a decrease in systolic blood pressure of greater than 40 millimeters of mercury. They have a paralytic ileus, so you can't hear bowel sounds, or oliguria, urine output of less than 30 mils an hour, or more specifically, less than 0.5 mils per kilogram for at least 2 hours. Now, this is diagnostic criteria. These are the things that Megan was saying. A lot of the hospitals now have SIRS and sepsis alerts. If 2 or more of these things are noted, boom, there's a flag that says we need a rapid response on this person. It looks like they might be septic. Okay.
Oh, and the other thing to add to number 4 is that you could either have that excess white blood cell, decreased white blood cell, or a shift to the left.
Which means those baby bands.
Yeah. So if we have greater than 10% bands as opposed to segs, which are the mature neutrophils, then that means we have an overwhelming bacterial infection usually is the cause.
Great.
And these are diagnostic criteria for SIRS.
Correct.
So SIRS you can have without sepsis, but sepsis you cannot have without SIRS except in extreme circumstances like in an immunodeficiency problem where your inflammatory response is not working, like in AIDS or like end-term AIDS. But for just across the board, you can have SIRS without sepsis with any type of tissue insult, but you cannot have sepsis without SIRS. So
very much like, hey, Meg, remember like when we talked about when there's infection, there's always inflammation.
Yes.
Just because there's inflammation doesn't mean there's infection.
Right. So the spectrum I like to go through is saying like, well, we start with SIRS if they meet 2 or more of these criteria. And I think there's also one included usually that's change in level of consciousness is also one. So if their Glasgow Coma scale drops more than, was it 3 points or 2 points? Mm-hmm. So that would be a way to measure it. So those would be 2 or more of those diagnostic criteria for SIRS. And then on top of that, sepsis is SIRS plus a confirmed infection anywhere. It could be a wound infection, UTI, it could be pneumonia, anything. If you have SIRS plus a confirmed infection, that's sepsis. And then as Ms. B had said earlier, if we have septic shock, that's inadequate systolic blood pressure will remain less than 90 in spite of adequate fluid resuscitation, which should be demonstrated by a CVP greater than 8.
Okay, pause.
Did I say that right?
Yeah, let's pause. Well, let's just go here for a second. Yes. Great, thank you, Megan. And so really, sepsis is a confirmed and or a suspected or die. So it can be just suspected. The person comes in, they look, their urine looks like crude oil, their white counts up, they're having dysuria. It's very highly suspected, but I haven't been able to get my culture back, okay? So we're not gonna wait until we get the culture back to treat them. They're considered septic too. So what do? Fluid treatment within the first 6 hours to include crystalloids. We don't usually bring colloids in for the very early on because we have to wait till that leaking pipe stop or all the fluid's gonna get pulled out of the pipes like Megan so brilliantly explained. We gotta get that CBP up to 8 to 12. Identify and treat the causative organism, determine the specific site of infection. So we're going to obtain blood cultures, urine cultures, sputum cultures, wound cultures. And by the way, a thing happened with my father. My father had back surgery that went really bad. And so then he had to have a suprapubic cath in because he was paralyzed. And so he would often have a urinary tract infection that would make him septic. We went into the hospital and they were drawing blood cultures. You're supposed to draw them from 2 different sites, 15 minutes apart, because you can get contaminants, okay? So the girl said to me, do you mind if I just draw it from the same spot? And I'm like, yes, I mind if you draw it from the same spot. What is your criteria? So anyway, always do what it says to do in your protocol because there's an evidence-based practice reason behind it. So we pan culture them. We don't wait for the results to come back because the person will go from sepsis into septic shock if we do, most likely. So we're going to give them a broad spectrum antibiotic, okay? And so do not let getting the culture deter you from getting that antibiotic in with that first hour. That is sepsis protocol. supportive measures to maintain hemodynamic stability. If I get their CVP up to 8 and they're still hypotensive, they've gone from septic to septic shock, okay? So I've got to add a vasopressor, okay? And then if I start seeing the person having organ dysfunction, now that is severe sepsis, okay? And
What I wanted to add too, Miss B,
Yeah.
for those who might be confused. So I know a lot of you have been looking at the tables in the books in the critical care section, and they have, hemodynamic monitoring. And yes, CVP is normal from 2 to 8 according to your textbook. But with septic shock, we actually want it higher, so 8 to 12.
yes.
So the numbers are a little bit different in the book as opposed to how septic shock is treated.
I am so glad you brought that up. That's brilliant. Okay, let's see here. Now I'm going to go
So
back.
we're just adjusting to the next handout.
Yes. Okay, so this is another handout because sepsis and septic shock are so deadly. And they go into SIRS and ARDS and MODS, or SIRS goes into sepsis and then it goes into MODS. By the way, it's not like a linear process. It can be kind of all over the place, and we're going to try to explain that as best as we could. Sepsis is the systemic inflammatory response to a suspected or documented infection. This is not a just local inflammatory. This is all through your system, including that hypercoagulability. All right, don't forget that clotting system like Megan talked about. The most common cause agent is gram-negative and positive bacteria, but other microorganisms such as viruses can cause it. Clinical manifestations, here's your general variables, and these 2 or more of the following are criteria for SIRS. Remember, if you have sepsis, you have SIRS, okay? SIRS can also be caused by other things, burns and things that don't have infection, but when you have sepsis, you have SIRS. So increased temp greater than 100.9, decreased temp less than 97, heart rate greater than 90, tachypnea. So the person is breathing at a rate of greater than 30 and or they're blowing off CO2 below 35. I would remember that too. Altered level of consciousness, a positive fluid balance of more than 20 mils per kilo per day, or you start seeing significant edema, and hyperglycemia. This is another one. Greater than 140 milligrams of diluted liter in the absence of diabetes. Why would you have that? Because you have a systemic inflammatory response and cortisol, your stress hormone, is being released by your little adrenal glands to beat the band.
Yes, that was exactly what I was hoping for.
Okay. Okay, leukocytosis with a white count greater than 12, leukocytopenia less than 4,000, and here's what Megan was saying. Or you have a 10% increase in band, so that's a shift to the left. Those immature ones are getting sent out. Increased CRP. What is CRP here? C-reactive protein. Any kind of inflammatory response, you're going to have that go up. Here's another really valuable tool that we look at a lot. Increase in procalcitonin. All right? And people who are septic are going to have increase in procalcitonin. You don't have to know the values. I don't think they're going to ask you that. But if they have an increase in procalcitonin, it is correlated with sepsis. I have done research on that. Why? I really don't think they know why. They just know
I actually went into the library databases and was like searching why, and I still never found anything.
No, it's very, pause it for 1 second. Okay. So the big thing you need to know is the level of procalcitonin in the blood will increase significantly when we have systemic bacterial infections and sepsis. We're not really sure exactly why, it just happens. And your CRP in any inflammatory process is going to be elevated, okay? Your systolic blood pressure will be less than 90, or there'll be a drop of greater than 40 millimeters of mercury, and your MAP is less than 70. We already hit these. Remember, septic shock is the presence of sepsis with hypotension despite adequate fluid resuscitation. You've got to get that CVP up between 8 and 12 to say that we've given adequate fluid resuscitation. And if at that point we still have hypotension, we are now in septic shock, okay? And that's going to lead to inadequate tissue perfusion. It has 3 major pathological effects: vasodilation, those endotoxins cause vasodilation. Fluid is going to leak out of my damaged pipes from the endothelial endotoxin, so now maldistribution of fluid where it shouldn't be. And there is a myocardial depressant factor released by these endotoxins it's going to damage the actual working, squeezing function of the myocardium. And that, like Megan talked about, they're probably going to die of cardiogenic shock. In severe septic shock, the body's inflammatory response is severely exaggerated. Endotoxins from the microorganisms will stimulate the body to release cytokines like tumor necrotic factor and interleukin-1, and a pro-inflammatory mediator like prostaglandins. Substances such as platelet activating factors result in microemboli. Remember, Megan talked about that. Now I've got these little clots, and they might be able to get through the bigger pipes, but as they go downstream into my fingers and my kidneys and my brain, they're going to get shoved into those little smaller vessels. That's going to prevent distal perfusion. All of these responses result in damage to the endothelium, vasodilation, increased tissue permeability, and your neutrophils, your white blood cells, and also platelets are going to aggregate and adhere to the endothelium, further decreasing your perfusion. Now, think about all the leaking, and I showed you what's going to happen in the lungs. Remember, your lungs are so vascular. The pulmonary vasculature, the alveolar capillary membrane, if you were able to spread it out, it would cover the surface area of a tennis court. So all of your vascular organs are going to be affected. Your heart, your lungs, your kidneys, your brain. So clinical manifestations, respiratory failure develops in 85% of clients with sepsis. And 40 of them will go on, not just into respiratory failure, but into acute respiratory distress syndrome. And the hallmark of that is when we cannot get a patient's PaO2, the amount of oxygen in their artery, above 60, even when we increase the FiO2, the fraction of inspired oxygen on the ventilator to greater than 60. That is a hallmark. We're going to talk more specifically, just wanted to mention that. So presence of invasive microorganism, changes in level of consciousness, decreased urinary output, GI issues, paralytic ileus, or maybe even bleeding. Metabolic acidosis develops from the buildup of lactic acid. So we do measure lactate levels because that tells us, is it progressing, getting worse, or is it getting better? IV fluids, we maintain treatment. The main treatment is to expand the volume. So probably 2 bore IVs with crystalloid solutions. Again, you don't want to give colloids right now in the acute stage while they're leaking, or it's going to make that fluid loss worse. But we're trying to give them crystalloid fluids at 30 mils per kilogram. The endpoint, what do I want to see? I got to get that CVP up between 8 and 12. I want my MAP greater than 65 and tissue organ perfusion. Listen, I can have a CVP that's normal and I can have a MAP that's normal. And if I'm not making urine, I don't have end tissue perfusion. So how do I know I have good end tissue perfusion? Normal level of consciousness, urine output greater than 30 an hour. Think about that. We don't treat numbers, we treat patients, okay? And each patient's a little bit different. These are guidelines. We're gonna give antibiotics. We're gonna give broad spectrums. And remember, your broad spectrums are like your ones that are nephrotoxic, okay? Your aminoglycosides. So we gotta be careful. We can actually damage the tubes, we can cause acute tubular necrosis of the kidneys if we're not watching our peak and troughs of our nephrotoxic antibiotics. Vasopressors, norepinephrine, Levophed, that's the first drug of choice if they're unresponsive to adequate fluid resuscitation. Vasopressin, what is vasopressin? It's ADH, okay? It may be added for clients who are in septic shock, whose bodies have already been depleted of their own pitressin or ADH. Remember, ADH makes us anti-diurese and hold on to fluid. It's a potent vasoconstrictor as well. Dobutamine may be needed due to vasopressors, which will help increase blood pressure and also decrease, no, we want to increase stroke volume. Dobutamine increases blood pressure, but dobutamine also decreases afterload. That might be a typo there.
A typo.
Dobutamine is often added to offset the decreases in stroke volume. We want to increase stroke volume. Low molecular weight heparin due to prophylaxis because of this massive pro-inflammatory and pro-coagulation, we want to prevent further clotting from occurring. And it might seem counterintuitive, but we'll talk about it. We want
to stop that DIC from happening. So that's why those low molecular weight heparins are instituted beforehand so that we can catch it, because, you know, in our American healthcare system, we think about, you know, treating diseases that already exist, but there's a way to prevent complications. You know, we learned in level 1, primary, secondary, tertiary prevention. And I want you to take those preventative tiers and think about them in terms of what can I expect to happen next, sort of like you learned anticipatory guidance in level 3. What can I expect to happen next, and what can I be doing to be proactive to prevent that from happening? So
Brilliant.
it's not just like, oh, I'm on alert and now my patient's crashing. It's like, what can I be doing now vigilantly to prevent that from happening? Going back to your last test, first degree AV block, we don't do nothing for that. We're constantly vigilantly assessing. So don't mistake that for doing nothing, because assessment is the key. And sometimes that's intuition. Honestly, you can't really teach that. It comes with experience and kind of, I don't know, this special sense of like having it. But if you have an intuition that something is wrong with your patient, go with it. The worst thing that happens is somebody gets irritated with you, honestly, and maybe like a little financial implication.
Go with your gut. You're never wrong.
Yeah.
Okay, wonderful. Now we have to also prevent further bleeding. So proton pump inhibitors to prevent stress ulcers, histamine 2 blockers like Zantac and Tag.
And please don't underestimate these, because I see students just glaze right over them all the time. They are very important. They may not be what's exactly saving your patient's life at the moment, but they're, like I said, preventative. So they're just as important as everything else. They just may not happen first.
Exactly. And don't let me forget, we're going to go into SIRS here and then into MODS, but I also want to talk about the stages of shock. Maybe we'll end with that so we can pull it all back together. Mm-hmm. So as SIRS, systemic inflammatory response can happen to a variety of causes. One main one is infection, but it can be ischemia, infarction, traumas, generalized inflammation in organs remote from the initial insult. Injury is characteristic of SIRS. So it's not just a localized, it is a systemic. So I love this diagram here, guys, because you can see if you are infected and you sepsis, you definitely have SIRS, but there are other reasons for it. Trauma, burns, pancreatitis. It can be a mechanical tissue trauma like burn or crush traumas, a surgical procedure, an abscess formation, intra-abdominal or extremities, ischemia or infarcted tissue, pancreatitis, that's a big one. MI, peripheral vascular disease, global perfusion deficits like post-cardiac resuscitation and prolonged shock states, and microbial invasions, bacteria, viruses, and that's the one we're kind of focusing on. You must remember that sepsis is a common cause, but not the only cause of SIRS. But if you have sepsis, you have SIRS. Excessive chemical mediators, we've already talked about this, but sometimes by the third time it kicks in, your cytokines like tumor necrosis factor, interleukins, and your oxygen-free radicals. All of those things will help lead to widespread endothelial injury and dysfunction, vasodilation, and leaky pipes because of increased capillary permeability. Capillary permeability.
You're going to get sick of us saying it. We're just going to keep saying it over and over again.
Now, the neutrophils are going to get entrapped, those wonderful little white blood cells that are trying to eat up the debris of this whole nonsense and kill those bacteria. They're going to get trapped in the microcirculation because of all the microvascular clotting. Transitions from SIRS to MOD is not a clear-cut continuum, okay? And your table 6710 is a kind of a good one to look at. That was in the 9th edition. But
the other thing is that those neutrophils are entrapped from that vasoconstriction, and also some of those inflammatory mediators cause the vasospasm too. So that can cause poor perfusion as well. The weird thing is about those inflammatory mediators is they're like the ultimate multitaskers. Like when you look at serotonin and then you think about it in terms of psych, it has so many different roles. Like prostaglandins, for instance. Prostaglandins are mainly associated with the inflammatory response, but they also initiate the RAS system, which is part of the reason why they're so elevated in early pregnancy, because the pregnant woman needs to expand blood volume at least 50% in order to provide perfusion to the placenta.
Exactly. And this is how you can remember that prostaglandins are pro-inflammatory, because prostaglandin sounds like prostitute, and a prostitute has to excite you and cause vasodilation to certain areas in order for her to fulfill
certain areas of the body.
Anyway, that would not be in your textbook.
We're all talking anatomically correct. If you guys think it's funny, then you're the immature ones.
Okay, Cardiovascular dysfunction, you're gonna have decreased systemic vascular resistance because you got vasodilation, blood pressure down, MAP down, but your heart rate's gonna be up because of razzmatazz. Cardiac output and stroke
Unless
volume
it's
initially
neurogenic.
be up, okay? Lung dysfunction, severe dyspnea, tachypnea, VQ mismatch. What do we mean by that? VQ mismatch simply means for every 1 unit of ventilation, oh, you can't see that, can you? Let me stop share for 1 second and
I got it.
got it?
Yep.
So for every 1 unit of ventilation, my alveoli, there is 1 part perfusion. So here's my ventilation, here's my perfusion. Well, what's happening is my perfusion is having issues. I'm leaking out fluid, and now my alveoli is full of fluid. So I have I don't have a 1-to-1 relationship of ventilation to perfusion, okay?
For every 1 cubic milliliter of blood, there should be 1 cubic milliliter of air or
Gas
centimeter of
exchange.
air.
Brilliant.
Mhm.
Okay, let me go back to sharing screen. Okay, share, there we go. All right, so lung dysfunction, severe dyspnea, tachypnea, VQ mismatch, and refractory hypoxemia. Remember, if we start getting PaO2 of less than 60, and we've increased their amount of oxygen we're giving them to over 60%, we're gonna go into ARDS, acute respiratory distress syndrome. GI dysfunction, mucosal ischemia, translocation of bacteria. Remember, part of our mucosal GI mucus is to keep bacteria in the gut and not let it go anywhere else. But if it's not being eliminated from our body and the systemic inflammatory response is letting all capillaries leak, then guess what? My GI tract is going to get leaky gut, and those bacteria, even my normal flora, can now translocate back into my pipes and cause me to have septicemia. Liver dysfunction. If your bilirubin's getting greater than 2 milligrams per diluted liter, you have an increase in all of your liver function tests, your ALT, AST, GGT, increase in serum ammonia, and decrease in albumin. Don't forget the liver manufactures albumin, and that is what is the major oncotic pulling pressure. The other thing, don't forget the liver takes lactate and converts it to bicarb. So as the liver fails, we're going more and more into metabolic acidosis because we have increased hydrogen, decreased bicarb. What does all this do to my central nervous system? I get acute changes in level of consciousness, fever, and seizures. Renal dysfunction. If it's a pre-renal cause, don't worry about all the difference between pre-renal and intra until your 4th test, but your BUN and creatinine ratio is going to go up greater than 20-to-1. You'll have less urine sodium. You're going to have increased urine osmolality and increased urine specific gravity. And if it actually causes, remember your creatinine is a much better indicator. So your creatinine should not be greater than 1 because that is the breakdown of muscle metabolism. Whereas your BUN is a breakdown of all protein metabolism. So intrarenal, once we start getting so much damage, it's actually damaging the your tubules inside your kidney. That's acute tubular necrosis. And we're going to see BUN and creatinine either go down or up, increase urine sodium greater than 20, and decrease urine osmolality. Honestly, guys, think about an increased creatinine, a decreased EGFR less than 60, and your urine output is less than 30 an hour. That's what I would focus on. The rest of that stuff can make you crazy. All right, so once this SIRS leads to organ failure of more than 2, we have MODS. So if on a test question it says that, I don't know, they have an increased BUN and an increased creatinine, they have decreased urine, that's all talking about one organ system.
Yeah, please don't miss those questions because it's really not, it's not what you think it is. What you want to do is make sure that each lab value in that answer is associated with 2 separate systems. So for example, like Ms. B is saying, if it's all related to kidney, they're not in MODS yet, 2 or more. So if it's related to kidney and then, oh, I see I have like some like troponin, there's cardiac damage, then I could say it's cardiovascular and renal.
That's right.
So please, that's one of those like gimme questions, to be honest.
That's right.
You just have to, what I would recommend if you're having trouble with that is making a table and saying like which lab values correspond, which diagnostics tests correspond to which organ systems.
Yes, that will help you. So MODS is failure of 2 or more organ systems in a severely ill client who's hemodynamically unstable despite fluid resuscitation. It's a clear result of SIRS. Now, the transition from SIRS to MODS is not clear cut. It doesn't go from here to the kidneys or here to the lungs, and then it goes here. No, it can go all at once or one for a while and not the other. It takes a while, but it has to have 2 organ systems failing to showing failing, like liver function tests up and your BUN and creatinine up, and now we have MODS. What we have here is that in both of these syndromes, the respiratory system is the first to show signs most of the time because it's very vascular. As more organs fail, 3 or more, the mortality rate is 70 to 80%, okay? What causes this? Any injury that results in systemic inflammatory response. We already talked about that because of the release of chemical mediators, which cause direct. Okay, so we're continuing on here, and we're talking about MODS. And in both of these syndromes of SIRS and MODS, remember MODS is 2 or more organs, 2 or more organs are failing, the mortality rate is going to increase. And if we get 3 different organ systems failing, we're up to 70 to 80% of mortality. Now, let's go down here. We're going to skip through some of this because I've already talked to you about it. But clinical manifestations are really based on inflammation, tissue hypoxia, and hypermetabolism. The respiratory system is usually the first to go. So clients with ARDS need aggressive pulmonary management. We're going to talk about that. I've already talked to you about the 2 different types of pneumocytes. Pneumocyte 1 is the alveolar cells themselves, and pneumocyte 2 is what produces surfactant. So if we have pulmonary edema because the alveolar capillary membrane is leaking, this is going to increase shunting of blood. Shunting of blood means wasted blood flow. Blood is flowing by an alveoli that is collapsed, which is going to worsen our ventilation perfusion mismatch. We're no longer going to have 1 unit of ventilation for every 1 unit of perfusion. This is going to decrease oxygen availability, specifically to the myocardium. The body's going to try to compensate by this massive vasodilation, which, by the way, the massive vasodilation decreases our systemic vascular resistance and decreases our blood pressure. Baroreceptors, which are sensitive to pressure in the carotid and aorta, will release inotropic and chronotropic factors to improve cardiac output. But remember, we only have so much epi and norepi in our body. The client becomes tachycardic and warm, but decreased SVR. Other manifestations are decreased capillary refill, increased CVP, because now as the lungs are getting full of fluid, it's harder to push the blood from the right ventricle into this pulmonary edema-filled lung. So I'm going to CVP is going to go up.
Pulmonary vascular resistance increases.
Yes, which is telling me that my right side's failing, and as my left side starts to fail, my pulmonary artery wedge pressure is going to go up, and I'll start seeing cardiac dysrhythmias, PVCs, runs in VTAC, maybe even VFib. Usually cardiac dysrhythmia is what kills these people. Acute change in mental status, maybe early signs of SIRS or MODS. Remember what the kidney's doing, it's razzmatazz. We're not going to go through that again, but you better be watching their BUN and creatinine and their EGFR. And if you're giving them aminoglycosides, you better be watching your peaks and troughs and keeping them within that therapeutic range so we don't fry their already damaged kidneys. GI system, we already talked about that. I'm not going to over belabor it, so you better use those medications, the PPIs and the other medications to help prevent GI bleeding. And remember, we're using up a lot of glucose, okay? We're using up a lot of our glycogen stores. So our body's going to switch from using glucose to using amino acids and fats, gluconeogenesis, and that's going to deplete our protein stores and start breaking down our muscles. Okay, remember, early in MODS, you're going to be hyperglycemic, blood sugar greater than 140, because of that wonderful thing called cortisol. The liver, increased demands on the liver to convert lactate to glucose, leading to increased levels of lactic acid because it can no longer convert bicarb, lactic acid into bicarb. It'll eventually begin to fail, so it can't synthesize proteins. Your liver function tests are going to go up. Your ammonia levels might go up, and ammonia is very toxic to the neurosystem. A patient with liver failure it is not beneficial to administer albumin. Latent MODS clients will become hypoglycemic because it's not going to work anymore. The liver also synthesizes our blood clotting factors. So when we start talking about DIC, we're going to have to give this person clotting factors because it's a bleeding and clotting disorder, which we'll talk about. When clotting factors are decreased due to liver function failing, the client is at risk for DIC. Electrolyte imbalances, hypokalemia, release of epi and norepi drive potassium back into the cell. Remember, increase in hydrogen ions, they're positively charged cations, they're going to come into the cell, and potassium is going to move out, right? But eventually, because of epi and norepi, it's going to drive potassium back into the cell, and we're going to have low levels of potassium, hypomagnesium, hypocalcemia, and hypophosphatemia, which all of those things lead to cardiac dysrhythmias. If more than 3 organs fail, then your prognosis decreases up to about 70 to 80% mortality, and the most common cause of death is sepsis. So what do? Recognize it early. Prevent hospital-acquired infections. Guys, go through your CODIs. How do I prevent that? Go through your bundles of how to prevent a ventilator-associated infection by keeping the head up at 30 degrees. Strict sterile technique. Good oral care with hydroxychloroquine at least once a shift. All those things are vitally important to prevent a hospital-acquired infection. Make sure that when you're changing A lines and central lines, you're using strict sterile technique.
One thing I wanted to bring up about this in terms of like actual clinical practice too, because you don't hear this very often from people, and there's this social culture in the hospital that everyone's got each other's backs. And there's definitely a different dynamic between like surgeons and nurses depending on personality. It's not always like that. For me, I had, more personality conflicts with like nurses than I did doctors. But what I'm trying to say is, if you are part of a procedure requiring sterile technique and you see that someone breaks sterile technique, it is your obligation to say something and to say that that needs to be corrected, because that's someone's life. And I know it's awkward. That's why I brought those relationships up. But there is a way that you can do it that maintains your responsibility as a nurse, but you're your patient's advocate. So it's really important that even if I remember when I first was learning to put Foley catheters in, and I was doing them as a PCT, and because I had gotten that certification, and I noticed, somebody, missed the urethra in a female and then is just going to try to stick it right into the urethra from the vagina. Well, the urethra is supposed to stay relatively sterile. So it's our job as nurses to face that awkwardness and say, no, this needs to be sterile. This is a patient who's at high risk for sepsis. It doesn't even matter if they're at high risk. If it's a breach of sterile technique, that needs to be dealt with.
Brilliant. That's so true. Okay, so we're going to treat infections. We're going to maintain tissue oxygenation. Hypoxemia frequently occurs with SIRS and MODS. Interventions to decrease oxygen demand and increase oxygen supply. By this time, the person's going to be intubated on a ventilator. They're going to be sedated to decrease their metabolic needs. We're going to give them pain medication, optimize high hemoglobin delivery. We have to make sure that their hemoglobin is at normal levels, because we have to want to promote oxygen perfusion. And this client may be put on PEEP. PEEP is positive end expiratory pressure to maintain a PaO2 of 80 to 100. So let me show you this right there. I'm going to stop share for a second so you can see my face. And you can see here what happens with a person that's going into ARDS, acute respiratory distress syndrome. Remember, we have the leaky capillary, and then the fluid goes here, then the fluid goes in here, and pretty soon I have atelectic alveoli, okay? So I have to blow those back up in order for there to be gas exchange. So let me just show you the difference. When we put you on a ventilator, we're going to select a tidal volume. How much volume is going to go in and out in each breath, okay? We're going to also say FiO2. How much oxygen are we giving you? Then there's different settings. Don't worry too much about that. But know there is a positive pressure, meaning the ventilator is going to put pressure in as you inhale, and then you're going to passively exhale and inhale and exhale. Now, PEEP is positive end expiratory pressure. So what it's doing is positive pressure gives me the inhalation, but as I exhale, PEEP goes and puts pressure in my airways, because your airways kind of automatically collapse during expiration. PEEP, positive end of expiration, as I exhale, at the end, it's going to go and blow more volume into my alveoli to kind of snap them open. Okay, so that's what PEEP is. I'm going to go back to snap share here, or share, whatever this is. And
so many different apps to keep track of.
I know, right? I'm sorry. Okay, so we want to try to keep their PaO2 about 80 to 100. We want to give them adequate calorie and protein. So we try to use the enteral route if we can, use the gut, but a lot of times we have to use it parenteral. But just remember, when you put a central line in, now you've got another direct avenue for a infection.
And that's one of those things they mention in the book, that's we want to initiate nutritional support for patients that are in the ICU undergoing some sort of trauma or shock within 3 days.
Exactly. They tried to do enteral feeding for me after my 13 hours of surgery, and my gut had shut down. So at one point I actually had an NG down decompressing my gut, and then they put a jejunostomy tube down lower to try to get my gut to wake up. And it eventually did, because they put a central line in to give me parenteral, and I spiked at temple 104. So they immediately took it out because they didn't want me to be septic. Okay, so appropriate support for feeling organs. The ARDS, acute respiratory distress syndrome, and that's when you have a PaO2 of less than 60, even though we've given you an FiO2 of greater than 60%. DIC appropriate blood products, we're going to talk about that specifically, and renal failure, they may need dialysis. Finally, it might be a consideration that further interventions are futile. Keep open communication with significant others. All right, we're going to talk about ARDS, but I want to share my screen here in just 1 second. I want to bring something else up. I had a couple really good pictures.
And while you're doing that, one thing I kind of wanted to discuss was, you know, we talk about multiple organ dysfunction syndrome as a result of sepsis and SIRS. Multiple organ dysfunction syndrome, like we said, is the failure of 2 or more organ systems. ARDS is essentially under that umbrella. So if you can kind of categorize it and classify it, things start to make a little bit more sense. If you notice, you know, that PaO2 is not where it should be in spite of that FiO2 of 60%, then we can say that they're in ARDS, which can qualify them to be in MODS if another system is failing, because remember, it's 2 or more. But when I realized that ARDS was this sort of, and so is DIC. DIC is also a failure of the hematologic system. So if you understand MODS as this umbrella term to describe each system, is this one failed? Is this one failed? Well, then if there are 2 or more of those, then that's what's qualifying the patient to be in MODS diagnostically.
Megan, it's not letting me open up my pictures here that I had to go ahead and pause it for a minute here.
Yeah, Zoom.
So guys, here's what's going on with this SIRS advancing to MODS is here's my pipe, here's the interstitial space, and here's my alveoli, right? Okay, and now we have, look what's happening. I have leaking pipes, and pro-inflammatories are leaking out, proteins are leaking out, pulling fluid in here, and also getting fluid into my alveoli. My alveoli is getting thick and non-distendable, and it's damaging my type 1 and 2 cells. And when it damages the type 2 pneumocytes, it's going to wash out the surfactant, which is that phospholipid lining that helps keep those open, and that's why we need PEEP. Can you show the next ARD slide, please?
Yeah, is that the one with the lungs?
Yes. So what happens is we're going to start seeing pulmonary edema, and this is what the x-ray is going to look at. I have a picture here of a normal lung as opposed to a lung in ARDS. Okay, well, here's acute respiratory distress syndrome. Here's what a healthy alveoli looks like. It's kind of like a bunch of grapes, right? Surrounding your airway, the cluster and cluster of grapes. These are nice open alveoli. They stay open during inspiration and expiration, making you have a normal ventilation perfusion match. But here's what happens: thickening of the walls and fluid inside the alveoli prevent gas exchange. And then I think I have one of the x-ray.
Yeah, I got that one
the
here.
Normal to the whiteout. I want to show you that. Okay, so here's what a kind of normal x-ray looks like. And you can see the costophrenic angles down here, and this big thing in the middle of the mediastinum is the heart. There's your clavicles, and here's your ribs, okay? And and now you look over here and you see total whiteout. That total whiteout is fluid. Air is translucent, it should be dark, and we see whiteout. So that is not a good sign. That is one of the things we will see at ARDS. Was there anything else for ARDS that I had in those pictures, Megan? Or
I'll pause the
maybe,
share real quick so I could check.
okay.
I have SIRS to MODS, treatment of MI, perfusion,
Let's do this
normal
SIRS to MODS.
SIRS to MODS.
Just to kind of show them, this was kind of a good illustration of how the systemic inflammatory response syndrome affects each of the different organs and can lead to multi-organ dysfunction.
Gotcha. So I'm gonna start, oh wait, we have been recording, okay.
Okay.
I thought I paused it, but I guess not. Forgive us, we thought we were paused. Okay,
right.
Go ahead.
Now do we have, I'm still seeing the chest x-ray.
Really?
Yeah.
Okay, let me try one more time. I'm gonna stop share screen. Which one did you want again?
The SIRS to MODS.
Yeah.
Just so we can kind of show, oh, there we go. Okay, so this, and I think this is, you have something very similar in your book here, but all these different things, low blood flow, leading to systemic inflammatory response, and then it shows, can you pull it up a little bit? It shows how it affects, I don't know what's down there, the different organs. Okay, so anyway, it just is a nice flow diagram, flow map, that's good, you're good, of how the different shock, low blood flow states decreases and leads to SIRS, right? And what SIRS does because of all the pro-cytokines, massive vasodilation, increased capillary permeability, and then we lead to dysfunction of each organ. Okay, you can get off that. We'll go back to that. I'll take over and go back to my handout, which is, where's our handout? Pause for 1 second, please.
Yeah.
Yes?
Yes, we're good. We're resumed.
Okay, so just so you understand, acute respiratory failure is not a disease, but it's a symptom of an underlying pathology that's compromising lung function. Okay, sorry guys. Acute respiratory failure is not a disease, but a symptom of underlying pathology that compromises lung function. So oxygen CO2 exchange is compromised, and it results in gas exchange dysfunction. Insufficient amounts of oxygen being transferred to the blood. So we already talked to this. I have said it at least 8 times. A PaO2 of less than 60 when you have the FiO2 greater than 60. It can be caused by pneumonia, toxic inhalation. You can read through there. Clinical manifestations, dyspnea, tachypnea. When you see the person having a prolonged expiration, using nasal flaring or use of accessory muscles, don't wait for paradoxical chest movement or signs of cyanosis. That is a late sign. The PaO2 is way below 60 then. Central nervous system signs are very early on: agitation, disorientation, delirium, confusion. We'll see tachycardia, hypertension, cool, clammy skin. You're going to see signs of shock, guys. Late signs are dysrhythmias and hypotension. Don't wait for that. Also, carbon dioxide, for lack of a better term, is a lighter gas, so it's easier to diffuse than oxygen. So you'll see decrease in PaO2, okay? And you still may have a normal CO2. When your CO2 starts rising, that's ventilatory failure. Hypercapnia is an ominous sign, okay? If we start seeing that, we're gonna have issues. You can read this on your own. Clinical manifestations, they might have to use the tripod position. We can help them with pursed lip breathing. But if this person has gone into SIRS and ARDS, they're gonna be intubated, okay? So keep on coming down here. Oxygen therapy, we have to get them on a positive pressure ventilation. Sometimes we'll try non-invasive and then go to invasive, so you can put them on CPAP or BiPAP, because BiPAP can actually kind of give them pressure inhalation and exhalation. It can actually give them some PEEP. Bronchodilators to open up their airways. We might have to use some anti-inflammatories like Solumedrol to stop that inflammatory process, to stop that leaking of the vessels. Get rid of that excess fluid, loop diuretics like Lasix. Give them anti-anxiolytic agents like morphine or Ativan. Antibiotics, because most likely some of these people are going to be septic, and we don't want them to become septic if they aren't already. Support adequate nutritional parenteral nutrition. Acute respiratory distress syndrome is a sudden progressive form of acute respiratory failure in which the alveolar capillary membrane is damaged, and we have plasma fluid leaking into the interstitial space and filling up the alveoli. The severity is measured, it's measured by a ratio of PF
and that is your PaO2 divided by the amount of FiO2 that you are inhaling. It should be greater than 400. Like if you take my ABG right now, it should be like 95. And I'm breathing room air. So if you take 95 and divide it by 0.21, that gives you your P to F ratio, okay? So if I have a patient who's on a ventilator and I have them on 60% and their PaO2 is 70, then I'm gonna take 70 and divide it by 6.60. And what you get is the PF ratio, and it keeps dropping and getting worse and worse and worse. And if it gets less than 200, you know that that person has ARDS, okay? Don't worry too much. You guys can read this in your own time. There's 3 different phases: injury, exudative, reparative. And what we try to do, guys, is get it, because you only have 2 weeks before we have a fibrotic change in the lung, diffuse scarring, and now you're never getting this back, and that person's most likely going to die. Look at him.
And if you look at the whole phases, it's essentially the inflammatory response. You're just applying it to the lungs. So look, we have injury exudative, vasodilation, increased capillary permeability, reparative, where collagen's deposited, and then eventually fibrotic, where you have non-compliant scar tissue. That's what happens on our skin. It's happening in our lungs now.
Brilliant. And what you want to do, remember, is it's going to decrease our surfactant. So we want to try to stop the injury as quick as we can within that 24 to 48 hours, support their respiratory function, and then do what we need to do to stop this inflammatory process from leading to more dense fibrous tissue being laid down from collagen, like Megan said, or we're going to have the fibrotic stage, and that person's not usually going to come back from that. Progression of ARDS varies among clients. If the pulmonary edema resolves, they may make a full recovery. I was in ARDS after the plane crash, and thank God I made a full recovery. I have no respiratory compromise. The most common cause of ARDS is sepsis, because we said the most common cause of SIRS is sepsis. Other potential causes may be direct lung injury from smoke inhalation, or systemic responses to inflammation from other causes, burns, trauma, what have you. Clinical manifestation: initial presentation is subtle. The client may not exhibit signs of respiratory difficulty. They may show signs of tachypnea, dyspnea, a cough, restlessness. Listen to their lungs. If you hear scattered fine crackles, that is crackles in the alveoli. If you start hearing it where it's more coarse, now it's coming up into the airways. So that is never good. Look at your ABGs. It may show initially respiratory alkalosis as that patient is blowing off CO2 because they're hyperventilating, and you're going to see some hypoxemia. Once you start seeing that CO2 go up, hypercapnia, we're in advanced stages. As ARDS progresses, the client will exhibit signs of pulmonary distress, such as tachypnea, accessory muscles. Remember, your pulmonary wedge pressure does not increase, because this is not a cardiac etiology. This is a pulmonary edema not related to the heart. When ARDS progresses, it's associated with profound respiratory distress. They require treatment of endotracheal intubation and positive pressure ventilation. Clients will progress into a state of metabolic acidosis, okay? Administration of oxygen, the goal is to correct the hypoxemia. A lot of times they have to have high flow oxygen. Most of the time it's going to be 60 or greater. We try to keep them on the lowest amount that we can, but we've got to give their PaO2 between 80 and 100, okay? The longer you have oxygen on a patient, oxygen actually can cause issues and damage to tissue, so we want to try to keep it as low as we can. Here's the big thing you need to know: positive pressure ventilation with PEEP. We started at 10 to 20 centimeters of water, and it's to increase what we call the functional residual capacity. When I inhale and I exhale, I never fully exhale. There's always some volume in there keeping those alveoli open. Though that's your functional residual capacity. So when I give PEEP, I'm going to increase that and blow open my alveoli to increase the VQ, to increase the gas exchange area. Now, the problem is when I increase that intrathoracic pressure, I also put pressure around my vena cava, which decreases my stroke volume, which is going to decrease my decreases my preload, which can decrease my stroke volume, thus decreasing my cardiac output. Also, the more pressure I put in there, that can cause barotrauma. I can actually blow little alveoli apart and cause a pneumo. So we want to use the smallest amount of PEEP that we can. Don't forget to go over ventilator-associated complications like pneumonia. Please know that contributing factors of impaired client immune system, increased metabolic state. They're already in a stress response. That's going to make them at increased risk for problems here. Okay. And remember, when the gut stops working, we translocate our normal flora, and that can make things worse. So interventions to prevent VAP, ventilator-associated pneumonia. Keep that head up 35 to 45 degrees. But remember, you got to be moving this patient. You want to be using all the good areas of the lung, and we rotate them because we want to promote pulmonary hygiene, getting airways clear, getting secretions out. Wash your hands before and after caring for clients. Perform oral care using pediatric or adult soft toothbrushes at least twice a day, at least once a shift, and use chlorhexidine oral rinse. Section oral cavity as well as the pharynx. Frequently use oral swabs with hydrogen peroxide about every 2 to 4 hours. Look at your vent alarms. There's always going to be a question or two about this. If you have a vent alarm, that means there is a problem, okay? So you always want to go in and look at your client. A low pressure alarm means they've become disconnected. So you're going to figure out where they became disconnected and reconnect them.
I'm very familiar with that alarm, Miss B, because when you put me in the neuro ICU for management, I believe I told you about that patient that Melissa and I had. Where she was on her she wanted a third valve replacement. She was IV drug abuse and had endocarditis because the bacterial accumulation on the valves.
Oh my God.
Well, she had been there for months, and the surgeons were refusing a third valve replacement because she weighed like 78 pounds, 22 years old. She looked like she was 80. Well, you know, she would press the call button, and if we didn't come within 5 minutes, she disconnected her vent. I have no idea. She was on a propofol drip. I have no idea how she was awake.
Wow.
But she would pull it off, and we were like, oh, there she goes again. And then when we would like go fix it and, you know, kind of leave if she needed us again, one time she actually chewed through her PICC line.
Oh my God.
Her teeth that had like Levophed and propofol. They had to rotate us, but because we were 2-on-1, we were able to take her for a couple days. But anyway, I'm familiar with that low pressure alarm. It means it's disconnected. It means that patient needs some attention.
Immediately. Oh my goodness. And a high pressure alarm could be the patient could be chomping down on their endotracheal tube, or they could have a mucus plug. So the best thing to do is take them off the ventilator and use an ambu bag to bag them. That way you can feel the compliance. If it's really difficult to bag them, we got to decide, is it a airway plug by a mucus clot, or do we have a pneumothorax? So I would be, make sure you understand that they need adequate moisture. They need adequate suctioning. So review how you do your suctioning, never more than, I don't know what the book says, 3 to 10 seconds. I always tell students, hold your own breath. Don't ever, and hyperventilate them before you suction them.
Yeah, for the intubated patient, I believe, and correct me if I'm wrong, you hyperventilate them, and you can do up to 2 passes for them at 10 seconds each.
Okay, that sounds right. Okay, now we're gonna go. I think
normally they, with like a trach that's not ventilated, they say 3, but with the vent, they say 2.
Okay. Are you still seeing my screen?
I see you. Your lovely
so
face.
I got to come back here and share my screen one more time because I'm changing to the DIC handout. All right, we're on the downhill slide here. Okay, are we still going, Meg?
Yeah, we're good. I can see you.
We're still here. Okay, so the last thing we're going to talk about is DIC. And Megan, when we talk about thrombocytopenia, I'm going to have you bring up that one picture, okay? Because a lot of people haven't seen petechiae. I said thrombocytopenia. That's not what I meant, petechiae. But I'll tell you in a second. So just like ARDS, DIC is not a disease process in itself. It's a abnormal response that was caused by something else. It's a complication resulting from an underlying disease. So we have to figure out what the underlying disease process is, fix that before this will stop. So we call disseminated intravascular coagulation also coagulation consumption coagulopathy because we actually use up all of our clotting factors. So it's an abnormal response of the normal cascade caused by an underlying disease or condition. So like Megan said, when you have those pro-inflammatory cytokines, it also kicks off our clotting mechanisms. So let's go through this. Causes. A huge one is sepsis, infection, gram-negative, gram-positive, obstetrical complications, placentia previa, all that kind of stuff, heat stroke, shock, especially septic, and you can read the other ones, cardiac arrest, sometimes poisonous snake bites, trauma, especially crush or burns. I had crush trauma and I went into DIC. So regardless of the cause, DIC is a serious bleeding disorder resulting from initiated and accelerated clotting. So what that means is I started clotting and using up all of my clotting factors to the point that I can no longer clot. So bear with me. So initially, I have accelerated clotting. That's a thrombosis. When I make a clot, that's called a thrombus, causing generalized activation of prothrombin and therefore an excess of thrombin. Now, the cool thing about thrombin is it's the most powerful coagulant catalyzer. And what does it do? Remember, in this clotting factor, one thing happens and then the next, and then something has to come in to make the next step become the next step. Well, thrombin makes fibrinogen. I always say if you put fiber in the gin, like an old cotton gin, it will make fibrin. And fibrin is like a really sticky spider web. You've ever walked into a spider web and you can't even see it and you can't get out of it. That's what fibrin is. Fibrin, the excess thrombin converts fibrogen, a sticky protein, to fibrin, which is a matrix material resembling a spider web, producing fibrin clots in the microcirculation. So if there's a spider web hanging out, especially in those small pipes, as the platelets come through, the thrombocytes, they'll stick in there and form the sticky fibrin matrix, promotes platelet disposition in the capillaries, leading to thrombosis and ultimately causing small vessel occlusions. So the thrombocytes get stuck in that fibrin spider web and I have a thrombus. Clots or thrombosis within the blood vessel obviously blocks perfusion. So I'm going to have decreased oxygen supply and supply of other vital nutrients to tissues that are beyond that block or distal to the clot. The decreased perfusion leads to ischemia, injury, and infarct. We've gone through that numerous times, okay? The excessive clotting occurring within the microcirculation usually affects the kidneys and extremities, but also the lungs, brain, and GI tract, adrenals, and pituitaries. The excessive clotting process, now remember, you only have so many clotting factors that the liver makes at a set point in time. And if I'm in a shock state, my liver is not going to be able to do that. So the excessive clotting process in turn leads to decreased available clotting factors, hypoprothrombemia, low platelets, thrombocytopenia, less than 150,000, and deficiencies in factors 10 and 13 resulting in hemorrhage. The thrombin circulating in the blood vessel also activates the fibrinolytic system. So we have homeostasis in normal situations. If I form a thrombosis, then my fibrinolytic system comes in and chews up that fibrin, that little spider web, so that I can break down the clot, okay? So the fibrinolytic system lyses or dissolves newly formed clots, breaking them into quote unquote fibrin degradation products or fibrin split products. Just think of it as breaking up that little spider web into little tiny spots. These fibrogen split products, anticoagulant byproducts, they also inhibit clotting. Now, concisely, DIC is kind of a paradox. You start, it's a bleeding that resulted in the fact that you used up all your platelets and clotting factors. So when that surge started and you went into a procoagulation, you started using up all your prothrombin, making thrombin, making fibrinogen into fibrin. My platelets got stuck in there and I used it all up. So guess what now? I'm bleeding. Okay, so what are we gonna see here? Come on down here. Clinical manifestations, bleeding or oozing from multiple sites. Petechiae, and would you put that up for us, Megan?
Yeah.
I have a picture because not a lot of people have seen petechiae. Petechiae and purpura. Petechiae are the smallest little lesions, and she's got some purpura and petechiae. Okay, I hope you can see that that's really abnormal. But that it might not be that glaring. It might be in some small area over the abdomen, or when you turn them, you see it on their back or out in their extremities. Okay, because again, this usually happens in the microcirculation, the most distal places. Okay, we can go back to the other one. Thanks, Megan.
Yeah.
Okay, now I'll go back to screen share and go back here, and you should be able to see that. Are we back?
Yep. Just wait.
Okay.
Yep.
Clinical manifestations, look at multiple sites. Okay, so look at where you have IV sites, central line sites, the Foley, petechiae and bruising, hematomas. Look in their gums. Do they have gingival bleeding or bleeding from sites of the surgical or invasive procedures? After my accident, they had done a bilateral fempop bypass to restore blood to my legs. They had done fasciotomies, and they had wrapped my legs in all this God's and within 20 minutes, they were blood soaked because I was in DIC. And the nurses picked up on it and realized that they had to give me more clotting factors. They gave me fresh frozen plasma. They gave me more platelets to get my help me get back into homeostasis. They also noticed that I had some hematuria. They also noticed that I had myoglobinuria. I had broken down proteins from the crushed trauma, and those proteins, those myoglobins, had actually clogged up my kidneys. And so they flushed me with high levels of fluid and bicarb to prevent me from going into chronic renal failure. Rapid onset of unexplained bruising, microthrombus leading to bluish discoloration of your fingers and toes, also called acrosonosis. Other related symptoms, dyspnea, oliguria, seizures, severe muscle, back pain, and again, signs and symptoms of multi-organ failure. The complication, you can hemorrhage, shock, leading to MODS, okay? Now, what I would spend some time on here, guys, is knowing, obviously, what the clinical presentation is going to be. The patient's bleeding, and they're also clotting. So you're going to see decreased perfusion, but you're going to see bleeding in areas where they shouldn't be bleeding, around puncture sites, in their gums, in the sclera of their eye. So what are you going to see? Well, I'm using up all my clotting factors, and I'm having a hard time clotting. So my PT and my PTT and my bleeding time are all going to be elevated. Because the thrombolytic system is breaking up that fibrin, my fibrogen split products, also called fibrogen degradation products, are going to be elevated. And my D-dimer, which is the most specific marker for the degree of DIC, because it's specifically a polymer that results from the breakdown of fibrin and not fibrinogen. Okay, just remember, D-dimer up is the most specific. Platelets and fibrinogen levels are going to be down because I'm using them, right? So those clotting factors will be down, but my bleeding time, PT, PTT, fibrogen split products, and my D-dimer will be up. I'm probably going to see an increase in BUN, and I'm going to see an increase in creatinine and a decrease in my EGFR because it's going to be clogging my kidneys. All right, now this sounds a little counterintuitive, but it's caused by bleeding that resulted from hyperclotting. So I'm going to give heparin, and that's going to prevent further clotting. It treats the cause, and then I have to replenish my clotting factors. So I'm going to give thrombocytes. I'm going to give platelets to correct the thrombocytopenia. I'm going to give cryoprecipitate because it specifically replaces factors 8 and fibrinogen. All right, remember I have to have fibrinogen to make fibrin. And then FFP, which is fresh frozen plasma, that replaces all my clotting factors except the platelets. It also provides a source of antithrombin. And remember, if I'm in a shock state that led to this, my liver is no longer making those, so I have to replace them. I also have to make sure I'm giving adequate red blood cells to increase that oxygen carrying capacity, okay? I may need to infuse heparin to prevent further microocclusion of the small vessels. And it seems counterintuitive when somebody is oozing around their IV sites to be giving heparin, but remember, you're trying to stop this cascade. Here are some of your nursing diagnoses and related interventions. You'll have deficient fluid volume, hemorrhage related to depletion of clotting factors, fear related to threat to well-being, ineffective protection, risk for ineffective tissue perfusion. So what am I going to do? Monitor their cardiac, respiratory, and neurological status, assess breath sounds, vital signs, cardiac rhythm, assess for signs of hemorrhage and hypovolemic shock, inspect their skin and mucous membranes for signs of bleeding. Remember to roll them over. Remember, just because I have a pulse does not mean I have good, adequate distal perfusion, so check that capillary refill. Check your IV and puncture sites frequently. Apply pressure during the injection sites for at least 15 minutes. Administer oxygen. Check your ABGs. Keep the demands on this patient down. They need to be up in a semi-Fowler's position to maximize lung expansion. Monitor their diagnostic labs, specifically PT, PTT, your FTPs and platelets, your D-dimer, your BUN and creatinine. Administer blood as necessary, fresh frozen plasma, platelets, like we talked about. Monitor that INO hourly. Remember, your kidneys are the eyes into the soul of the cardiovascular system. Monitor for potential complications, including pulmonary emboli, acute tubular necrosis, and multi-organ dysfunction syndrome. Provide emotional support to the patient and family. Okay, so most of the time, these people are going into DIC here in our situation because they went into a shock state first. There was SIRS, and then they go into MODS. And the hematological system is a system. So it's if we start seeing DIC, we realize that the hematological system has succumbed to that prolonged decreased perfusion state.
And that would be part of MODS.
Yes.
Yeah. So I would say overall, I know that was a lot. DIC, you definitely want to know the various causes, even outside of shock. So like how we mentioned, metastatic cancer, any obstetric complications, but you also need to have this tattooed on your brain. You want to know exactly what the labs are going to look like, because we need to be vigilant, especially if we have a patient who, specifically if this is caused by sepsis, that we're watching those panels in terms of clotting.
Megan, something that I just remembered, when we were talking about septic shock, we were talking about how we have to give them fluid volume replacement and get that CVP up to 8 to 12 before we'll put them on a vasopressor.
Mm-hmm.
Another way that we can test to see if they have adequate fluid is a passive leg raise.
Right, I saw that too.
Lift the legs, right? Because that will take about 150 to 500 mils back to the cardiac and increase preload, increase stroke volume. If you see a positive response, an increase in their cardiac output or cardiac index, and obviously this person's in the ICU with hemodynamic monitoring, then we know that we can give them more fluid, right? And if not, then we're going to give them more fluid until, or we're going to give them fluid. If it doesn't make a difference, then we have to go right into vasopressors. So
Okay,
I found that was very interesting in here.
Yeah, good stuff.
Can you think of anything else that we forgot? I'm just trying to.
Other than those topics we weren't able to cover, including, ES1, you better run, all the different.
Oh, let's do that.
All the different trauma ones.
Let's just go over those really quickly because I have that goofy saying.
Okay, yeah, let's do that.
So if it's, pause it 1 second.
Yeah.
Okay.
So magically, Miss B came up with chest tubes. It was a very beautiful magical trick if you didn't notice.
I carry them with me at all times. You just never know when you're going to have a trauma situation, like you're going to be in a plane crash. Okay. So anyway, remember that when we have to put a chest tube in, it's because we've disrupted that negative pleural space around the lung, and it becomes positive and it puts pressure on our lung and our lung deflates. So we need to get a chest tube in there. And sometimes we can just take a large bore needle and go to your second intercostal space, mid-clavicular line, and stick that in and let the pressure come out to stop the person from getting a tension pneumo. But the definitive treatment is putting a chest tube in. And we usually put it mid-axillary, about 4th space, because we can get air, and a lot of times there's trauma and there's bleeding. So I want to show you, these are 2 different types of collection units. This is one water, and this one is dry. The only difference is in the water one, I put water in the suction column, and I take the water up as high as I want the suction, whether it be 5 centimeters of water suction, 10, 15, or 20, okay? And you should see continuous bubbling there, meaning the suction is working. You don't want rapid, like, because that will use up all the water. You want just general, continuous bubbling in the water suction chamber. The only difference with the dry one is where the suction is, you just turn it on here, and this little orange bellow will come on, and you'll know that the suction is on, and then you just turn it to where you want it. Both of them have the water seal indicator. Both the dry and the wet have the water seal indicator. And what that means is you're going to look in there. When they initially put the chest tube in, you might have a little bubbling there, but you should not have continuous bubbling in the water seal section. It's much like if I took the chest tube and I put it underwater. Okay, if air is leaking out, I would see bubbling, okay? But I don't want to see continuous bubbling because that means there's probably an air leak. So where do I want to see continuous bubbling? In the suction chamber, but not in the water seal chamber. Something else you might see in the water seal chamber is what we call tidling. As they inhale and exhale, it'll rise and fall, totally normal. When it stops, I got to go listen to their lung sounds. Maybe their lung fully expanded, or maybe there's a kink. Maybe there's something blocking it. Okay. If I have continuous bubbling in the water seal section, go to the patient. Make sure I have an occlusive dressing around where that tube goes in. I don't want any air being able to get sucked into that, because that can further the pneumo and lead to tension pneumo. These are your collection chambers, because it's not just going to be air. There's going to be serous fluid, maybe even some sanguineous fluid, and you're going to mark it each shift and determine how much. You never want to have more like 100 out or 200 in an hour. And a lot of times these people come back from having open heart surgery and they'll have these. So you really need to make sure that you're watching them closely, okay? Because this is a place where they can hemorrhage, especially if they went into something like DIC.
And
Now,
in the hospital, they also do mark every so often, periodically
Every
based
shift.
on your hospital protocol.
Right.
You're
you
going to
time
be
it,
marking the time, and you're going to be putting your initials there as well.
Now, if you have a chest tube, okay, it goes in between the intercostal spaces, and then it hooks up to your device, and there's going to be tape there to prevent this. It's going to be airtight. You're going to take like a petroleum gauze of some sort to wrap it around the insertion site. It's going to be sutured in there, okay? Now, what can happen is if somebody, like, say, pulls out the chest tube, okay, and now you have a gaping hole there. You never put an occlusive fully dressing, right? You put a 3-prong dressing so that when they expire, air can come out, and then it would go like this to not bring air back in, all right? If the chest tube is still in, but it got disconnected from the collection device, okay? Say the chest tube is still hanging out, what I can do is take it and put it underwater. Just stick it in a cup of water, because that makes it like a water seal. Listen, if I didn't have water there, I could use whatever fluid was nearby to prevent, because if this is just dangling out there, air can be coming in each time I inhale and making the pneumothorax worse and actually leading to a tension pneumothorax. So I think those are the big things that you need to know when you're covering chest tubes. Don't forget also with trauma that you have to make sure the scene is safe. Go look at all, like Megan said, go look at all your biohazardous stuff. And also with trauma, worry about where you could be bleeding that you might not see it. Cullen sign, intra-abdominal peritoneal bleeding, retroperitoneal bleeding, you've got gray Turners, okay? So think about those things. Is there anything else, Megan, you can think of?
Did we talk about the 3-sided dressing in case the whole tube comes out? Did you mention that?
That I did just mention that. If
Okay,
the whole
sorry, I
thing came
zoned.
out, that you wouldn't put a full occlusive dressing. Pause 1 second. I forgot about the ES1. Okay, so for our last thing we're going to talk about is the 5-level emergency severity index, which is on table 68.2. And so there's a lot of information there, so I'm going to try to keep it like simple. So I always say if it's ES1, you got to run, right? You got to get in there right away. That patient's unstable, they're life-threatening situation. How soon does the HCP need to get in there? Immediately. You need high resource intensity, right? So HS1, you got to run. HS2, prevent code blue. So it's the patient is threatened, likely but not always obvious. They need to be seen within 10 minutes, okay? This is still high resource intensity, multiple, often complex diagnostic studies. They need frequent consultations. So this could be like chest pain, but as an ES1, that's like cardiac arrest, okay?
Yeah, like chest pain, like ES1 would be like a STEMI. And then maybe ES2 could be like a non-STEMI, because they tend to go to the cath lab within 12 to 72 hours, whereas a STEMI goes within 90 minutes.
Mm-hmm. I like it. And obviously a cardiac arrest, you better get in there, they're done.
Yeah,
okay,
you gotta get in
ES3,
there.
I can wait and see, up to 1 hour. Medium to high resource. This is like somebody with abdominal pain, gynecological disorders, hip fracture in an older patient. So that's ES3. I can wait and see, maybe up to an hour.
One thing I want to mention about fractures real quick is if you have a fracture of the femur, that's more acute, because that
really
femoral artery is very big. So
that is very true. That is very true. At ES4, they walked in the door. Okay, so we could delay seeing them for a while. They just might need some simple diagnostic X-ray, closed extremity trauma, a simple laceration, cystitis, something like that. And then ES5 is jive. okay? They probably shouldn't be in the ER. They maybe just have, it's low resource, maybe have cold symptoms, a minor burn.
They're just a
Check.
hypochondriac.
I didn't want to say that.
I'll say
Attention
it.
seeking. So if you think
I
that-
tend to be a hypochondriac sometimes.
I don't believe that. If you just ES1 got to run, ES2 prevent code blue, ES3 I can wait and see, ES4 they walked in the door, ES5 it's probably jive. That might help you in that little scale. It has been a pleasure. In this, I'm
Yes.
kind of getting emotional because this is my last hoorah for a while at least with Megan, and I so have enjoyed it. And we hope that these workshops have been helpful to you guys. If
Yeah,
so,
thank
make
you
sure
guys
let
so
us know.
much.
If they
Yeah.
haven't been helpful, let us know that too.
Yeah, let us know. And
In a sweet way.
if you need some content covered that we didn't cover in this section, because there is a lot of it, I know,
Yes.
please reach out to NIP. If you go to the NIP student comments, fill out the student tutoring request and send it to either Dr. Lisa Leonard, our manager, or Susan Arthur, our receptionist. That's found under NIP student comments. You click on course content, and then there's a little bar that says need a tutor, and it explains everything within that. So if you feel like, you didn't get exactly everything you needed from this workshop, we only had a couple hours, so we covered the big points, but feel free to reach out and ask for a little more help with maybe one-on-one tutoring. All right, guys, thanks so much for joining us. Bye.